Shall I start? Okay. Welcome, everyone. It gives me immense pleasure to welcome you all to the book launch of my dear friend, Dr. Supriya Subramani. The book, as you see, is called Passive Patient Culture in India, Disrespect in Law and Medicine. It is published under Routledge Research and Health Law series. My name is Priya. I teach at TAPMI Manipal. And Supriya does a lot of things, apart from, of course, that she's written this book. But to introduce her formally, like all of us know her, but to introduce her formally, she's a lecturer at Sydney Health Ethics School of Public Health, Faculty of Medicine and Health, University of Sydney. So she's here on fieldwork, and it's good for us that she's here at this time, and we get to hear from the author herself. She explores ethics, embodied emotions, and the politics of knowledge. Employing critical philosophical ethnography and a phenomenological approach, she critically examines structural injustice in health, disrespect and othering, the ethics of belonging, and the intersections of paternalism, respect, and agency. All the themes that will also come up in our discussion today. And along with this, she has also founded South Asian Bioethics Community, where we met. So when they did their first event in January 2023 is where I got to know about this through, I think IGME or maybe through Medico Friend Circle, through one of those, and that's how, we got in touch. And Supriya has done a great deal of work for us early career researchers in terms of providing a platform for those of us who work in healthcare ethics and justice to share our thoughts, our worries, our work. We give feedback to each other, a lot of those things. I've had the privilege to read a few chapters of this book before it came out, and now it is open access. Thank you so much, Supriya, for doing that by taking money out of your grant, and it was a huge sum of money that you took out because, let's face it, the publishing houses make it very difficult for us to buy books in India. So thank you so much, Supriya, for doing this for us. And the flow of the event will be like, first, Supriya will reflect on her book. She'll share an excerpt also from the book. Then we'll have a conversation with Dr. Amar, Jesani, and Dr. Sundar Sarukkai. And then we'll have a panel with Dr. Meena, Dr. Joga and Dr. Sylvia, where I will also be there as moderator. So yeah, welcome you all, and let's begin the event. Welcome, Supriya.
Thank you so much. That's a very kind and friendly way of knowing. I mean, I have met you for now, it's been almost 2 years, but it's so nice to get to know you, and you are being part of this, Priya. Thank you again. And thank you so much. I mean, it's really such a meaningful moment for me in my life. Of course, this has been 10 years of work since I started during my PhD, but way before too, I was a project associate at one of the Wellcome Trust projects. I started off in the space of bioethics, which is very, very new, at least when I started off. So I just wanted to say this. I'm so privileged and I'm very honored that my parents who are here and my family and my longtime peers are able to be part of this gathering. And it's such a privilege to have this moment with family and the longtime peers. So I'm really grateful for this moment. So like many scholars, I have been on a journey of learning and unlearning. It takes a long time for scholars, especially coming from not really a disciplinary, categorized or specialization. So it took me a long time to wrestle with where I situate and how do I position, and also find voice. What is my voice? It took me a long time, to be honest. So this book is very much a part of that process for me, which began in 2012. I joined as a project associate in IIT Madras, and that's something which took a long toll on me in different ways, and I managed to work within the space of health ethics and largely bioethics space. Although this book is built on my PhD work, which was in Chennai in 2 different hospitals and many healthcare professionals across both private and public hospital, as well as through the analysis of medical negligence cases, the time I've taken since then during my postdoctoral work allowed me to critically expand and deepen this work. So I use my doctoral work, but it's not my doctoral work. It's much more, I would see that as. So this book is another attempt, to be honest. I don't know whether it's a perfect attempt, but it's another attempt to center voices and experiences that have been dismissed, silenced, disregarded, and oppressed. It asks why we must center these voices and why resisting the culture of the passive patient in medicine and law in India is morally imperative and urgent. This work sits at the intersections of multiple disciplines, as I mentioned too, and I hope it challenges disciplinary boundaries and gatekeeping practices as I move between different approaches and frameworks, always with one key aim, that telling a key narrative, that is, Across institutions, particularly law and medicine, and within healthcare interactions, the archetype of passive patient is invoked to justify paternalistic and disrespectful treatment. The way we think about who is a patient is something which I wanted to convey, which is very common sense understanding or taken for granted understanding, but at the same time, I want to go deeper. What does it mean for us? So if I say, in a double quotation, of course, always, a typical Indian patient, what image comes to our mind? What does that say about our collective imagination, then, the question becomes. So when I think about my own visits to public hospitals, I'm sure in some of my experiences I have shared in the book, or even accompanying family members to small clinics, I realize there's an unspoken expectation to not ask too many questions. If you do, you're seen as being difficult or wasting the doctor's time. I have seen patients, of course, witnessing, and myself or my family members, silenced with just a look or a dismissive tone, the way you dress, the way you speak, the language you embody in different ways. So how often everyday indignities, and that's something which I started in my initial doctoral work, I was looking at micro inequalities, and I realized the more I was unpacking, I was unable to get the key aspect of why inequities matters, and then I developed into the larger, the theorization of everyday indignities, basically to capture how everyday, disrespectful experiences, attitude, and behaviors becomes normalized and accepted as something which is okay, and which allows this larger system, the oppressive hierarchical structures, to retain its, the structure intact, right? So, and the institutional norms and values, then it targets, the everyday indignities basically targets one's self-respect and one's true dignity. I call it true dignity just to my own vocabulary to understand that whenever we call ganate in Kannada, right, or sometimes it's on honor or self-esteem very often, sometimes it can be replaced depending on the context. But maryade, like whether it's in Tamil or even in Kannada, maryade, respect, can also be differently situated, depends on the context and the relationship which we have. Then what is true dignity for me is a question of how do we think about self-respect and with humanity is intact. Together is what I was trying to understand. It's something which is intersubjective. What does it mean is like in everyday interactions, when you experience disrespect, and that something is intersubjective, it's very part of the conversation. That's something which I've unpacked. The more I was listening and reading legal judgments, the image of typical Indian patient, that is like, who is this typical Indian patient in the judgments, or the way the judges think, or the healthcare professionals they think, is quite head down, waiting endlessly without protest, not questioning, compliant, blindly trusting the doctor. And I wonder, and of course argue in this work, that this image isn't or wasn't about us, that is who is the marginalized or the larger patients community, lacking intelligence or awareness. It is very often is about also survival, right? And it's a kind of an agency in its own way sometimes. So people who have learned that speaking up can mean being shouted at or skipped over or simply ignored. And when patients who do question can also experience challenges, of course, in its own way, because when you go to the, very often you would have experienced, when you ask questions in private hospital or even corporate hospitals, sometimes you are seen as a troublemaker. So then the question becomes is like, so as a patient, you are doomed if you ask questions. You are also seen as stupid, ignorant, and passive if you do, because you don't, because you assume that the Indian patients and typical Indian patients are passive, right? And this is in part of a judgment. The title comes from one of the Samira Kohli judgment, which actively says, use the word passive. Indian patients are passive and ignorant and incompetent. So then, by passive patient, that's what I mean, that an archetype that enables the treatment of people, especially those who are shamed, humiliated, silenced, and disregarded as if they were incompetent, passive, and arrogant or naive. It is deeply entangled. I mean, this is what I was trying to do in the first chapter, is like how it is deeply entangled with the colonial legacies and continuities, which is sustained by the upper caste class and gender hierarchies that continue to shape injustice in the larger healthcare institutions and also legal systems. So the idea that patients are passive or ignorant actually reveals more about how the system operates. It's not about the Indian patients this is the case, it's not a fact, right? It reveals more about how the system operates, how it demands compliance, how it demands obedience, and how it demands and discourages the dialogue, the conversation. That is, a patient is not seen as an agent, a respectful person to be engaged with. So the system is built to reward the silence and also punish assertiveness sometimes. or often, especially if you're a marginalized patients or population and communities from marginalized background. So the real ignorance is, or moral ignorance, I would say, is perhaps on the part of institutions and professionals who assume that silence means incompetence rather than a response to structural disrespect. So as I started working in the space of bioethics, very often, I'm sure some of you who are familiar with bioethics space, the conversation of autonomy is so, like patient autonomy is something is the go-to. The idea of the archetype of a patient in this discourse of global north, that is it's an active patient, right? The one who is informed, competent, able, who can make decisions. So then the question becomes the key question for me, and that's something which I've been trying to think, and the more conversation I'm hoping today is, how can we talk about active patient or the person to be seen as respectful agent, recognizing patient situatedness with intersectional and marginalized identities or any kind of categories we all belong to? It's not just one category we belong to, multiple and intersectional. So how do we recognize patient situatedness, embodied realities we all live in at different, especially for marginalized communities, and respecting as a person with true dignity in an oppressive structures and conditions? Can our public institutions, including healthcare and law, are capable of cultivating democratic ethics? I think this is something which Sundar would have a much more of, have to say around these questions. Or are they deeply shaped by exclusionary logics? That's something which, is a question which I've been struggling with. So then the question is can't we talk about dignity in oppressive structures? I mean, definitely people who are marginalized live with dignity. We all live with dignity, even in oppressive conditions. But then what's the struggle? How do we wrestle with these larger, marginalized, especially the systemic injustice and the larger institutional ethos which creates these conditions? So I just want to read quickly from my afterword, because that's something which I think a little bit of hope rather than showing all this about suffering. I mean, as a researcher, sometimes I feel like I'm exploiting people's narratives and stories because you show suffering and, hey, look at all this sad and, the deeper issues, which is sometimes there is no hope. I mean, I think even some of the conversation I've been having with my colleagues is where is hope then in this kind of a current climate? So here it is. I hope that by illustrating the othering, suffering, and humiliation experienced through everyday indignities by patients and family members in the Indian healthcare and legal system, and elsewhere, of course, by theorizing to emphasize recognition, self-respect, and agency, the conception of situated patient, I demonstrate resistance to the dominant status quo of upper caste, class, gendered, and racialized values, which normalize and reproduce disrespect towards those marginalized in our interpersonal relationships, and of course has become part of our institutional ethos in everyday realities. So most patients in India, especially those who seek care in public healthcare system, are acutely aware of how we are treated. Many choose to go along with it because they know, or we know, that questioning a healthcare professional might result in being mistreated or sometimes even pushed out of the hospital. So as we have seen in both law and medicine, that is across my chapters too, these reasoning patterns are used to justify paternalistic and authoritarian practices and decisions. So to conclude, if we seek social change, we must acknowledge the voices of the marginalized, those who are suffering, those who are humiliated and shamed, and learn how often oppressive institutions such as law and medicine in India practice authoritarianism and paternalism rooted in ingrained hierarchical values and norms. And of course, that resisting them is a part of it. So the silent suffering, this forced endurance from the largest conditions, is the heartbeat of paternalism in law and medicine, where control and power are justified through a narrative of care, a twisted story that says, we know what's best for you. And I think this is very familiar for many of us here. To suggest that people in India or patients in India need to be rescued is nothing but a colonial and upper caste class lie, a moral failure, right? It is the height of arrogance to assume that because someone lives within a political and social reality shaped by inequalities, they somehow don't know better, or that they listen out of blind trust. I think this is a very common narrative within healthcare professionals or also in legal judgments. This narrative, this paternalistic savior complex, does nothing but reinforce the very systems of oppression we should be dismantling. The truth is, the oppressed know. We know better than anyone. It is the privileged, the so-called educated authorities and experts who need to learn, we need to learn, We need to unlearn the comfort of power and authority and instead sit in the discomfort of listening. So we who are privileged must learn to listen, engage with, and recognize the voices of those at receiving end of disrespect. I hope in this book across, I have gone in and out of different disciplines to tell, as I said, to tell a key narrative and the theorization of this archetype of passive patient. I hope, and for me it was like, it becomes a liberatory for those who are marginalized. I hope it allows us to resist and acknowledge one's agency and finding a vocabulary which is often, at least I struggled my way through during my PhD journey or my research journey. Finding a vocabulary to locate and express explicitly for those positioned with unearned privilege to resist the culture of disrespect through recognition in everyday encounters and institutional protocols, guidelines, and policies. Furthermore, I hope it encourages the creation of opportunities and spaces that recognize that situated patients with self-respect and agency, as Ambedkarite philosophy, and that's a spirit which I carry across the work, and provide structures that stop blaming the Indian patient or population as labeling as passive, ignorant, or incompetent. Thank you. So now I am very much looking forward to this. The next, the aspect of this whole book launch event is a conversation with both Dr. Amar Jesani and Dr. Sundar Sarukkai. So what I thought is, like, first I'll invite Amar to come over and then have this conversation. I'm curious where this conversation leads to, definitely. So first I would like to invite, Amar Jesani to share some reflection. And today is his birthday too, and I'm like so happy and thankful that he is here with us. So happy birthday once again, Amar. And Amar is a respected researcher and teacher in the field of bioethics, which many of you know, I think, through Indian Journal of Medical Ethics. And he has been in this space, and he has been supporting many young researchers and scholars in the space for a very, very long time. And I met him, I think, in 2012, again, as part of the Wellcome Trust project. Yeah. And he's one of the founding members of the Forum for Medical Ethics Society and has played a pivotal role in shaping its flagship publication, of course, as I said, Indian Journal of Medical Ethics, which has been circulated in 1993. Right? A key figure in the medical ethics landscape in India, of course, and Amar was honored in 2022 with the Award for Bioethics Service in the face of challenges by International Association of Bioethics. So over the course of his career, of course, he has authored in many books, so much of work he has done, breadth of work. But again, as I said, I've been remained in touch, and there's many conversations. At least sometimes I just drop an email. I tend to send cold emails to people. I think people know here a little bit. But I'm happy to continue those relationship and conversations from then whenever I have sent a cold email, I think. So I'm really looking forward to listen to you, Amar. Yours?
Well, thanks for inviting me here, Supriya. And I must say, I really enjoyed reading the book. I not only enjoyed, but I was very envious because I could read from your book from where you come from, what kind of challenges that you face in your life and how those experiences really shaped your standpoint about what is happening and what you were, when you were collecting data and the kind of evidence that you were getting into. Envious also because you say that I have written some books, but they are not of real consequence when I read yours. Because I always had a one leg in academic, but my main work is outside academic. So I don't claim too much of academic credentials. I find, the kind of language that you have picked up after coming from vernacular like me is beyond me. My English is very, very atrocious at that level. Anyway, but it's really very remarkable book as far as I am concerned, because I resonate with many of the ideas that you have expressed there. What I'm going to say are three major things, because I have 10 minutes, and I thought these are the 3 points, maybe the good starting point. One thing that resonated with me is your contention that what happens to certain stratas of people in our society, the caste, the gender, the class, and those who are oppressed in those strata, is reflected in the health system. It's the same kind of reproduction there. And as a person who has come to bioethics and medical ethics, it just interests me that how is it that medicine allows those values to get into it, Because when I learned medical ethics in 1970s and early 80s, what I was told that the professionalization of the doctor, which includes the cultivation of ethics amongst them, is one of the ways of filtering out the regressive morality of the society and create a new morality of the health system or healthcare, which is superior to all of them, because that's how ethics says that you cannot discriminate. You have to treat equally everybody. Even a decade comes or a terrorist comes who is injured, you have to treat that person with the same respect as you do it with any big politicians coming there. This is what we were told. But what you are finding is that those filtering processes are gone. In the sense that the privileges and the power that certain people have in the society, the same power has permeated the healthcare system and the medical profession. So this is in a way, I would say, the kind of professionalization that has taken place here is very, very different as compared to, say, even in the developed countries. Developed countries, I learned as you started visiting, that in the formal level, when they are interacting with you as a doctor patients, they would definitely try to filter out some of their prejudices. It may come out in their, in the body language and very, very sophisticated way, but not the way on the face discrimination that you can see it in India, where the doctors are practicing. So this is very, very, different here. Ethics at the other level that I was told was very close to human rights. Because I come from the human rights tradition and then realized that if I have to survive as an activist in healthcare system, then if I talk about human rights, doctors are not going to listen to me. Or anybody in the health system is not going to listen to me. They listen to me if I say ethics. And there, for me, the ethics, as I oftentimes say, was the other side of the coin. Right? If you have a human rights as a patient, and if I'm interacting with you and treating you, your human rights become my ethical obligation, because I have to respect them. Most of the ethical standards that you talk about, the autonomy, the informed consent, none of them descended from above. They were not there earlier. They came simply because patients, instead of become passive, became active. They started talking back. Right? That's why medicine and social sciences are very different from physical sciences. This table can't do anything when I hit them, but if I hit you, you may hit me back, right? That's how the human beings are. But that's what's not happening. That's how ethics was a kind of a complement to the human rights, in order to actually implement the human rights in day-to-day practice. Ethics was a mediator which will protect the people who are weak in the process, in the relationships. Because your book is also talking about power relationship. And the power relationship, when we talk about, we have to talk about human rights of the people who are weaker there. And then the ethics of the people who are powerful to respect those things. That's how doctor-patient relationship I understood. Same way I understood it in research setting, because I am a researcher, that why do I have to respect those people who are, participant in the research? It's simply because it is my ethical duty to respect their human rights, protecting them. So ethics is a protector of the poor, of the weaker people in the relationship. But that's what is not happening. So that is what your book brings out in a very stark way. The second thing that I wanted to focus was what you have talked about, respect. And this respect issue is very important. I understand, because when I was reading your book, I had read bits and pieces of various authors that you have quoted, but you have put together all of them and synthesized them. And what does autonomy mean, and what is, respect. So I read Belmont report where the respect comes out is a big way. After the Tuskegee trial, in US, they appointed a committee, which was the Belmont Committee, and they came out with their own principles of research ethics. And the first principle was respect. there were beneficence and then justice and all. But when I looked at it, then I realized that actually respect covers everything. It's so broad. But if you reduce it to just autonomy, right, then it doesn't cover everything. If you respect somebody, how can you harm that person, right? So risk-benefit analysis you talk about, non-beneficence you talk about, that as a doctor, do no harm, whatever you do is for the benefit of the patient, is covered under the respect in many, many ways. So respect is for me it was very strong. And same way, you cannot be unfair to them. So justice is also, integrated into it. But that is provided. The respect that you are talking about is for the person and not for certain aspects of the person. So what has happened is that respect is reduced to taking consent. The consent becomes a process where somebody signs and says that, please do what you are intending to do. I mean, earlier it was worse because when I was a medical student, and in the night round, when you go as a student to look after your patients, the nurse will call you and say, hey, because we are all young students, they say, they give a piece of paper and say, your patient, go and get signature here. And when you look at it, you find that fellow is going for surgery tomorrow. And it says that I hereby consent to undergo surgery under any surgeon, under any anesthesia. It's a complete blanket thing, right? Now it has become more elaborate. Now you have to mention which surgery, which doctor, and this and that. That is the only change that has come about because of the challenge that comes from below. So that way, for me, I think the whole issue of respect and disrespect is extremely important because the recognition of the people who come to the healthcare and recognition of the people largely in the society as person is extremely important. And as it is happening in our society, I think it is also happening in the healthcare system, is that, yes, I recognize you as a person, provided you are a person of certain kind, otherwise not. And, that brings up a challenge that it's not that respect has gone out from the society. They want to respect only certain kind of people and not the other kind of people. And that's what is the predominant, the ideological as well as, the operational or way of treating people has come about. I was telling yesterday the story about, that when I was an avid reader of Holocaust literature. And when I went into ethics, the first thing that came to my mind is that why German doctors became like this. This is the same Germany. If you have read medical history, you will say this is the Germany where the scientific medicine was born and nurtured, right? The doctors were highly scientific and they were, oriented to what we call evidence-based as that. Each doctor's clinic was also a laboratory where they will do research. So research and clinical practice was integrated there. And if you look at ethical standards of early 19th century, they all developed in Germany, Prussia and Germany, not in USA and UK. I mean, I'm talking about the formal articulation of guidelines and the laws that happened there. And yet, by the time 1930s come, things change. And you see all the atrocities by the doctors there. Something like 55 to 60% of all German doctors were part of the Nazi party. And how did it happen? And then the answer came it very simple, that they remain ethical. They continue to respect, but they continue to respect only the Aryan German and not the rest of the people. So if you change the definition of the person, then disrespect becomes integral part without you realizing that it is there, right? If some certain atrocities take place, we come out with arms on the streets. And when the other atrocities take place, which is worse than the earlier one, we all say that, oh, it happens, this is the thing. That's the way we change. And so that whole disrespect issue is not just informed consent and that kind of thing. It is more about how do you recognize a human being as a human being. Because there's a lot of criticism of medicine also that they look at human being as machines, they look at only organs and all. But we also try to understand that they also, dissect them at the level of social understanding of the person. And the last point I wanted to make, which I think you have gone into it quite a lot, is about patient, Patient and the people. That's what I was struggling when I was reading your thing. I think, how are these two connected? And how do we take them together? Because you are talked about passive patient, active patient, you are talking about situated patient, all kind of stuff. When I meet doctors and interact with them, I find that for them there are only two types of patients. There are submissive patients and there are angry patients. The submissives are all those who accept whatever instructions they are providing. And angry they are afraid of all the time. And if you talk to doctors and you scratch them and ask them that, who are you the most afraid of in your day-to-day practice? They said patient. When they should be the friends of the patient, right? Because there is a lot of anger among the patient. And any discussion about violence within the health system gets hijacked by how the doctors are engendered in the entire stuff. But if you look at the evidence base, then you will find that patients are more, facing violence within the healthcare system, both physical violence as well as medical violence, as well as psychological and emotional violence. You'll work with nurses, and you'll find that there's a lot of violence against them within the healthcare system. All those things are very invisible violence. I came to, because I was a public health researcher, social science researcher, the first time I realized that how people are sometimes not recognized as patients was from the invisibility of some kind of people who are patient. I think you have mentioned that in your thing about, how some people who suffer from certain problems and still they do not go around and present themselves in a clinic as patient. I think you have given the example of your granny and all, doing household remedies and all kind of stuff. But in mid-90s, we wanted to find out, because at that time there was a massive debate, and that was also time when health insurance was conceptualized, hospital insurance. And T.N. Krishnans and all those economists were involved with a big UNDP grant that they had got. And we wanted to find out actually at that time that why the health-seeking behavior data in the surveys, in NSSO data, as well as the other data that were coming out, was showing that people who should have been healthy are being shown as the people who are having more morbidity than people whom we expect to be unhealthy. They are showing less morbidity. So in Bihar, you'll find the morbidity reporting was very, very low. But if you're in Kerala, it was the highest, right? Because there was a more health seeking by them as compared to people in Bihar. So the visible and invisible patient is also very, very important there. The second aspect that occurred to me was, what does the active patient do? Just go there and really try to push back the power of the doctor and the health system? Or does something more than that? And that's where my last point in this is that, how do you expect a larger structural healthcare reform to take place? And in India, my experience is that people expect health organizations like Medico Friend Circle, Jan Swasthya Abhiyan to lead revolution in the healthcare system. And that is, I think, a very pathetic situation to my understanding. They cannot, because they are largely from medical profession or connected to the medical profession. I have not seen a single historical example anywhere in the world where people coming from health system actually reformed it and made it universal access. You study what happened after Second World War in UK and how the national health system was created. You look at what happened in Canada, and you'll find at every place, people who reformed the system were not the medical people. On the contrary, the national level medical association oppose it tooth and nail till the end. The British Medical Association, today it supports NHS, but the government wants to privatize it, right? But in 1948, when Beveridge Committee report came out, they were against it. Only small group of socialist doctors were supporting it. In Canada, when in order to have a universal access law in 1971, when they were planning it in 1960s, doctors went on strike twice against it, saying that we don't want universal access, right? So I haven't seen a single example where doctors have actually helped in reforming the system. And one of the reasons why they succeeded was that people who are non-doctors stopped getting intimidated by what is called medicine. And in India, I find that as soon as anything related to healthcare comes, the gaze goes to somebody who is sitting there from the healthcare, rather than people who actually use the services and experience the services. They are not the ones who are at the forefront. Look at how education became fundamental rights in India. Who led that? Because everybody knew that education leads to upper mobility. Parents, families, and a lot of people who were not teachers. It's not the teachers' union, but it's the people who are general who give a push. Fortunately, we had a good teachers' union who also provided a certain kind of support to them. But largely, it came from the civil society. That's why it is very, very important to underscore this, that it's not just being active patients within that, but they have to become active reformer of the health services from the outside. I often say, while teaching universal access to healthcare services and bioethics, I ask this question to my students, because nowadays people talk a lot about our own indigenous traditions and that kind of stuff. I said, see, we keep talking about Vasudhaiva Kutumbakam. We say that whole world is family. That's why Bengaluru is a family, Karnataka is a family, India is a family, right? But when it comes to doing something for each other, we don't. We keep our own premises clean, but not the things outside. And you say that the Western countries, they are individualistic. And so they are inferior, morally inferior to us than us, because we have a very higher concept of what is called, humanity as a family. But look at the history. How is it they could build universal access healthcare services, and none of us who are from South Asia, excepting Thailand and those kind of Eastern Asian countries, and perhaps Sri Lanka as an honorable exception, we have not really been able to achieve that. And I think we have to combine that individualism with the collectivism. How do we ensure that those who are able-bodied, earning well, are going to be subsidizing those who are children and those who are old people in order to create a society which finances the healthcare for everybody. And at the same time, empowers them to such an extent that having just universal access is not sufficient. They can still have gender biases in it. They can still have caste biases in it. That's what has been happening to European society too. They have biases against migrants and all kind of people. So we have to also to empower the people who fall sick and go to the health system, and particularly from the societies which are highly oppressed and I think that is what I can take from your book, and I hope it will be read by many people and then interpreted from their own experiences, and all of them contributing into a larger health movement, which is, as I said, more and more people from civil society lead it. Thank you.
Amar. Thank you so much. I mean, I think the key aspect which I keep thinking about as I was listening to you is about how the movement, the movement comes through from the larger public, and then why. And I wonder, where is the moral outrage, right? As you were talking for the health, there is no fundamental right to health, but education we somehow manage, but there is no moral outrage for why can't we make health as a fundamental right and having patients' rights as a key aspect. I think that's something which I'm learning, like how do we think about the larger collective movements which would start from us, basically, right? So now I'm really looking forward to conversation. There's so many lines and threads which I want to pick on. But next, I would like to invite Sundar. It's my great pleasure to introduce Sundar Sarukkai, philosopher, writer, and public thinker. He has a new novel too on what it is, and I'm really looking forward to read that, Sundar. Sundar has extensively, I think many of you know him, but I just want to quickly give you, key aspect or the larger overview of him. Sundar has worked extensively at the intersection of the natural and social sciences and has held key academic positions, including Professor of Philosophy at National Institute of Advanced Studies and founder director of the Manipal Center for Philosophy and Humanities. He is also the founder of Barefoot Philosophers, a beautiful initiative. I really like the way he approaches and to connect with public and why philosophy should matter, right? I mean, finally, the question is not abstract theorization or anywhere. It's about making meaningful change in the larger social chain. I think Sundar is doing this very beautifully, and I want to learn more about Barefoot Philosophers initiatives. So he has authored several influential books, of course, many of you have read, including The Cracked Mirror and Experiences, which I really enjoy with Gopal Guru, and The Social Life of Democracy. I think that's something which is like key thing which I kind of very much resonate with even with my work and the learnings which has happened over the years, since 2022, I guess. So his most recent work is a novel, as I said, Water Days. It's a novel. It's interesting the way he has been writing different academic, but at the same time he has moved into the fiction, would I call it? Yeah. So Sundar's work invites us to think deeply about experience, ethics, democracy, and the everyday. So I'm really grateful, and I look forward to listen to you and for the conversation, Sundar.
Thank you, Supriya. It's really an honor to be part of this discussion and dialogue and conversation, and lovely to listen to Amar again. You could have gone on. I could have just... I'll anyway make very brief comments because there's so many interesting points you've been saying. And all of us who have been even at the intersections of thinking about ethics and medicine and science, from my case, we know Amar's work for a very long time. And reading your book allowed me to place many of the concerns which has come to me from a more theoretical perspective and also from my engagement with the medical community to some extent, particularly in attempting to introduce medical ethics when I was at Manipal, for example. The tremendous challenges in doing that within the medical community, and that's something which we have spoken about earlier. So thank you for this invite. I'm really delighted to be part of this here. When Amar was saying about, what did he say? The two types of patients, submissive and angry. I'm reminded of a film which allows me the freedom to say that there are three types of patients. You have submissive, you have angry, and then you have the dead patient. And the reason I'm saying this very macabre figure of dead patient is from a very well-known Tamil film a few years back. And for those who may not know this, it was a very popular film. And the story is a family takes a patient and who's had some heart attack, whatever problem, and he takes him to the hospital, and the hospital people grab him and put him into they say we're taking him into the ICU. And then that's the end of the story. He never comes out of the ICU. You keep asking the doctors, they say, no, he's in the ICU. And they keep him for 3 days. And then they come and tell him he's dead. And then the story is about the discovery of this son of that man who has taken him into the hospital. He is discovered that that person has died 3 days back. And that the hospital kept him in the ICU, saying he is dead. Now, this of course looks like a very melodramatic Tamil film, right? But it is so surprising how many people have recounted similar stories to me. And I'm like, are they also as melodramatic as our films? Yeah, generally, Tamil Nadu, they tend to be. Since I come from there, I can say that. But the point is, it is true that this notion of passive patient is so massively brought into our consciousness when you begin to realize that the passivity is not just about my inability to ask the doctor. It's my inability to even know whether I'm alive or dead. That's a very different kind of an understanding of what our relationship with the doctor is. And, I think one of the most important things about a book like this, something which is very close to my heart, because I keep working I do some, even at the barefoot, whatever, it's something very simple. It's my own work. It's not about what I write and what other people read. It's about my attempt to understand the concepts we work with. That's all. Like if it's democracy, what does it actually mean? And then we recognize that trying to understand a concept in its most foundational sense means you have to draw upon many different things. We have to talk to all of you to understand. And that's something this book does very well. So you are saying, for example, the reviewer said it's not really medical. It does not matter. I think what we produce are not something within a discipline. We produce disciplines. That's what we should be doing, right? Because others have produced disciplines and we can do it. So that conversation is going to be difficult because some people will say, no, it's taking too many people, etc. That doesn't matter. The reason I'm saying this is, this book allows us to relook at this question of what is the meaning of a patient. Begin with such a simple thing. We take patient for granted. And very interestingly, of course, the origin of the word patient from the Latin use of it is to suffer, to endure. That's what it actually means. It's remarkable. Many concepts and words, let's say in English language, have undergone massive transition historically. But it's very remarkable that the word patient has been quite sturdy in its meaning. It's still about to suffer. Somebody to suffer, to endure. And that's why when say somebody gave a patient hearing, you have changed a very negative sense of the passivity of enduring into the quality of a listener, somebody who is, patiently listening and so on. So, sorry. Yeah. Oh, should I go back? Okay. Am I too close to this? I'm trying to have a human engagement with the audience because I'm standing here and, you seem so far away from where I am. So this question of weight. So the first thing the book does is, of course, to challenge this kind of a historical acceptance. In other words, it's challenging our passive acceptance of the passivity of a patient. And we have accepted it passively, other than a few of the activists, other than few people who have been writing books like you have. We have accepted passively. We don't have a say in the medical system. We don't have a say when we go to a doctor. For example, when this medical consent thing was there, when I was in that Manipal hospital, it's a very important hospital because KMC has had a great impact on many villages and towns around it. People used to come from Shimoga over the Ghats to bring patients in ambulance to KMC hospital in Manipal. People used to come from Kerala. So it's a very important hospital which gave access to all these people. But yet, the consent form was a joke. Once I had gone for something and they said, oh, I want to look at the consent form, and I couldn't make any sense of the consent form. All you have to do is to sign it. And then they thought they did something remarkable in giving, being very open and liberal about it. They said, we'll have to have, it actually came as a discussion in the ethics committee meeting, do you have the consent form in Kannada or in Malayalam? They said, we'll also introduce one in Malayalam. So many people come from Kerala. And you can have it in any language. You can give it in Swahili, people will sign it. Nobody's reading it, and if people who read it, we don't understand it. I have no clue what it says. And imagine, again, this is something that's happened in all our daily lives. People who go to a hospital, they go to the show, they say, sign this. You are signing it because it's become a kind of a ritual which absolutely empty signifier. So the passivity is really inbuilt. And I think it's a very nice way in which you also begin this book by saying that the major complaint of patients and family, that's a very important point from your ethnographic work, but the major complaints of patients and family is not about the physical pain alone. I'm sure physical pain matters, but about their treatment. This humiliation, this distancing, this rejection of them as individuals who are coming to them with questions. So a lot of the book is about that. And I'm very glad, among other things, bringing in your own experiences, that those subjectivities into the book is something very important. And I hope more medical people read this in that sense. And also I loved your use of Kannada words in between. And I wish it had more of it. It would have been more interesting. But I'm also very glad that the publishers allowed you to do that. So basically through all those are signposts. It's not whether, what does it matter, 10 Kannada words, ಏನಾಯ್ತು ತುಂಬ ಅಷ್ಟೊಂದು ಏನು ಡಿಫ್ರೆನ್ಸ್ ಆಗುತ್ತಾ ಅದು? No, it doesn't matter. It is a symbol. It's a way in which you are approaching this question, opening us up to saying, look, you need to take into account things which you are unfamiliar with, things which you are uncomfortable with, in order to be able to think through this question. And what is it that we have to think through? What is she demanding us to think through? This idea of passivity and the impact of passivity, particularly on those who have been denied basic human respect, dignity. And this, as I said, while she focuses on the question of the marginalized who have been largely of various kinds, various intersectionalities, we know it's also true across, and that is also something she acknowledges. But the point is there something of a greater moral weight on treating people who are already treated socially badly in this manner within hospitals? Now, one of the things which social scientists would immediately respond is to say, well, a medical institution or a hospital is a mini society. You cannot expect a hospital to behave differently than the larger society does. All the social habits and practices get manifested in society. So it's not a surprise that the society does, that the hospital behaves with you as the society outside does. So I would read this in the larger project as this: questioning the passivity of patient of these people within hospitals is a way to question the passivity of citizenship. It's not about the hospital alone. When you learn to articulate, when you learn to be able to ask your doctor, who is in a much greater power position vis-a-vis yourself as a patient, then you are in a far better position to be able to ask questions to power outside the hospital. So in that sense, the larger project, which is this ethical project, is something which I hope would be very useful, or something which doctors would look at more seriously. I don't have great faith in that after having seen, unlike doctors like Amar and his gang who have done, I think, phenomenal work in bringing IJME and these larger questions into the Indian public discourse, the community of medical doctors are a different tribe. So there's very little, I think, we can do. And I want to end with that, just make some points associated with that. Because I think, what is the challenge in saying, okay, I understand even as a patient, I want to have a say. People, all of us who go to doctors might want to have a say. What really is the fundamental obstacle to it, and how can we think about this as we go along, is one question which I want to talk about. So one of the important points which repeatedly occurs in the book are 2 points. Amar also mentioned this. One is about autonomy, the importance of the idea of autonomy. And the other, related to, I think, Supriya's own project, is about the question of self-respect. Okay, so the question of autonomy is very interesting. So the question of autonomy is what one could say that maybe the shift from passive to active can act when the patient shows some autonomous action. So autonomy, like she also have done in the book, we could draw many philosophers and others, Kantian and others, to talk about what the question of autonomy is. But the interesting point for me is that the conceptualization of autonomy runs into a serious problem within medical science communities. It not only within medical science communities, so let me put it this way: a parallel discussion in a different field, which has been happening over the last many decades, is in education. We have had the image of a student as a passive student. A lot of education has been, how do you make a passive student active? The question of passive student, where there is a teacher and there's a student who is just going to listen to the teacher, and it is just passive. And many times the critique of Indian education system was, our students are passive learners. They were not active learners. So the question is, how do you make them active? So that's why critical thinking, etc., became courses which schools and universities, now all private universities, begin with a course on critical thinking. I wish their management underwent the course first before they did it, because when I look at the models on critical thinking, I don't see any critical thinking. But critical thinking has become, because what that is doing is, it's producing a passive student and active student. But the question of autonomy is still very much present there too, in a very similar manner. So one of the ways they attack the question of autonomy there is to ask the question, is the authority of the teacher of paramount importance in a classroom? In other words, the way a student becomes active, this is the simplest formula. The way a student becomes active is to ask questions to the teacher. So all of our training, typically in critical thinking courses, are about training them to question the teacher. Now that, of course, now so many schools have done it as a de facto. You can go into many of the so-called alternate schools, the first thing they say is ask a question. Okay, so some schools allow it, some schools don't allow it, etc. In general, it has worked well, except at a particular point. And I think that's really where this problem of autonomy in medical, between patient-doctor, becomes really large. And this goes back to the foundational idea of what constitutes modern science. The problem about asking questions to doctors is really not even about one level, as you pointed out, it's a social process, and that's something which there is no excuse for that to happen, and that cannot be allowed to happen. Where people can treat a patient as if they are nobody, as if they can be discarded, and so on. Okay, that's a basic, as you're saying, some kind of a human right, or basic human, quality that one would expect. But every knowledge system is inherently makes the receivers passive. You go into a maths classroom and you have a mathematics teacher teaching you calculus. The student can ask questions of doubt. Oh, I don't understand what you're saying. But the student can't say, no, I think your whole formulation is wrong, or I don't accept that. Knowledge, by definition, produces silence in its receivers. And there is a mode, there's a whole, that's why in educational systems, very traditional education systems too, you're first supposed to listen, understand before you have the capacity to question, which is what now we are re-questioning in education. So, typically this is what happens in our normal practice. You go to a doctor, the doctor says, we are going to give you this particular treatment, some injection, something. So at the most I can say, I don't like injection, can you give me something else? I mean, I often do that. Sometimes when I travel, I get some stomach problem, I go to the doc and they'll say, I'll give you antibiotics. And I say, no, I don't want antibiotics. I don't take antibiotics. But if he tells me there is this particular thing, some whatever work it does and you have to take it, I don't have the capacity to be able to be active in face of my ignorance of that knowledge. The problem about passivity and activity, which is also, by the way, very interestingly related, unless we have questions, we won't talk about it here. In the context of the social exclusion, the fact passivity of citizenship or passivity of caste communities also comes because their access to that, their articulation of that knowledge is not there. They say, oh, what can you tell me about something? You don't know, so you can't talk, right? So how does one deal with this question then? So when doctors, even in the many wonderful examples you have given, they'll say, I'm impatient, what can I tell you? Suppose I tell the doctor, oh, you're taking an X-ray, are you sure you can see my lungs? No, is the doctor going to teach us what is biology, physics? So this is an excuse they've been using. So I'm not excusing them. I'm saying this become a very standard way in which say you don't know what I know, and therefore you cannot be. So this question of worthiness, another conceptual term you talk about here, in any knowledge domain, it's not just worthiness of just being an individual. So at one level, the concept of worthiness she talks about is very important, which is that I am worthy just by being me. I don't need to have anything. I don't need to have a degree. I don't need to be this and that in order for you to see me as a worthy human being. I am worthy in virtue of just being myself. But in the context of transactional relationships or interventionist transactional domain, like in medicine, medicine is not the social domain of human interaction. It is not just about all of us talking about things, or can you allow me to sit in front of you, etc. No. Medicine is particularly about transactional domain of knowledge. Now, the question there is, then worthiness is dictated by whether you are worthy of understanding me or whether you share my shared epistemic world. And this is the fundamental problem. So, therefore, how does one then look at it in the context? So, the shared question of the problem of autonomy in education and other stuff. And whether, and this just as an aside question, which I don't know how to even address it, but I think it's a very important question. How do you relook at the question of autonomy in the Indian context? In our everyday social with my Gopal Guru, we were really struggling with this question of what is so special to the everyday social, the social world. For one example is Indian societies are very strongly driven by family structures. As when I was set up this program in Manipal, I've had, students who are medical students come to us and say, I want to do philosophy or literature, but I can't do it because my parents are not, typically my father is not letting me. Then there are some point I can say, oh, you're anyway undergraduate, so you're already old enough. What do you want me to tell you? Do I tell you, no, go fight with your parents and come and join? What is it? I had a student who actually was so interested. He was doing communication engineering. He shifted, he came. He said, this is all I want to do. I want to do MA in philosophy. I said, I'll give you the seat today. You want to come? Join. And then he's telling me, my father won't let me. And this is really remarkable story in that sense. For me, I thought it was a question of autonomy. This fellow is 20 plus years old, and he's saying, his father is saying, don't do philosophy, and he's saying, I want to do philosophy, whatever happens. Then what he does? He couldn't come and join us. Because his father said, I'll send you to UK for 1 year course. He went to 1 year course, his father paid 15 lakhs or something, he did the course. And then I left the thing just as I was leaving. Then that year he applied. He had earned his own money. He came back and did MA philosophy. It's really remarkable that question of autonomy, and therefore a family plays a very important role. I think the questions of Kantian and the other traditions really miss this point out. How do you then define autonomy vis-a-vis a family relationship? Because you have these questions of what can a child do within the context of a family. So this actually has very deep, different kinds of implications on how we sociologically look at autonomy in the Indian context. And I think there's a lot of very interesting insights you have from your book, which I think will allow you to theorize that a little more into some very interesting. So without going on, I'll just end with these points, just as a set of questions which I think this makes us think about. There are similar questions about autonomy, also the question of agency. And one of the questions I'll just leave with you, which is I think at the foundation of much of the passivity is, are we as individuals capable of knowing our own illness? The problem about the passivity comes because we don't have the capacity to know our illness. And we needed a mediating person like the doctor to tell us that. And why I'm saying that is, this is something which I think is also a great challenge to do this, that there have been other medical cultures, including tribal medical practice, which I'm sure you're well aware of, in which this notion of passivity does not play out in this manner. What does that tell us about medical practice? Those two are hierarchical knowledge. Somebody has knowledge in systems, but their own practices of healing and their practices of community living and the meaning of health, illness, and healing are so different. So would that be a particular model for this? I say this because I want to just end with this. Therefore, this primary, I think what I hope the book will make its readers do, but definitely those of us in the community who are interested in this question, I definitely think this is what it is going to ask us to think about, is the larger question of what does it mean to be ethical under the constraint of knowledge and truth. That if I have this very clear-cut systems of hierarchies which are present in a domain of knowledge, how do we then define the idea of ethics? And secondly, that I think repeatedly with all the stories and other things, the book makes us keep repeatedly asking, at least it made me repeatedly ask a question, how do we activate the idea of the human in medical science? It's very ironic. Like Amar said, natural science is about tables and all that. That they accept and they are very comfortable doing what they want. Social science will say it's about societies and they also have very abstract social beings, Maybe anthropology deals much more with the human than anybody else. And that's why it's a very important discipline. But medical science is about the human. It's really ironical that among all the subjects, medical science is what is about the human, and there is no human in medical science. There's absolutely the lack at the core of medical science, the meaning of being human, other than a series of molecules and flesh and some kinds of actions of organs and so on. So how do you activate the idea of the human? How do you put the human back in the center of medical knowledge? That, I think, is something which really brings us back to some fundamental questions. And she talks about the idea of self-respect, and and I'm sure there's much she will say to us about it. Very important question which arises in the Indian social context with Ambedkar, then with Periyar, and how these ideas of self-respect actually animate the possibility of a kind of a more egalitarian society. How does that practice of self-respect with Periyar and Ambedkar come into medical practice? I mean, the very idea that you can even use words, names of Ambedkar and Periyar in medical school would be like shocking in a sense, but still, that challenge is what I think you pose to us, and maybe it is through these kinds of interventions that we can even begin to show to the medical science community the mirror that your medical science, which is about the human, is empty at its core, and we have to find ways to fill it up. Thank you.
Thank you so much, Sundar. The way I've been trying to connect the questions which you both kind of I know we are slowly running out of time for the session, but I will take a couple of questions, but it's also a common thread which I've been wondering with your thoughts and reflections on books. And first of all, thank you so much for being here, and also to critically engage with my work and asking me certain questions which I've been also thinking around, especially around the idea of autonomy. I think I was struggling, to be honest, in the beginning. I mean, as every other, at least philosophy-leaning scholars who tend to, take the Kant, and which I did work with initially, and then I was struggling my way through where is this larger social relationship and embeddedness, especially the larger political situatedness. Sorry. The larger political, embeddedness, especially the positioning of a person, where we sit matters how we talk, and how we are receiving, whether we are treated with dignity or whether we are treated with respect. Right? I mean, that we are very familiar with. You both were trying to understand, put in the human rights perspective with Amar, and you were questioning the larger family. And I remember reading in your work, I mean, I think it's around the family. I think you touch upon the family. In Indian setting, we have a family. But then you have mentioned in your work about family is paternalistic, right? I mean, completely, we have a father, which you mentioned, the mother as a nurse, and then a child is usually the patient. And then it's very clearly a hierarchical setup. And growing up myself, like my mom used to also say, like, "Tirige elbada." In Kannada, basically is whenever you ask question, because you're talking about never question your parents, never ask questions. Don't. In Tirige elbada is like basically don't question back, right? So going back to the fundamental idea of like a patient can't question the doctor because of the expertise which is there. But then, if a child questions back, and I think the answer lies in what your example of a student, he exercised the agency. He did exercise the agency, but maybe it took some time to figure out the relationship with the parents, right? And the same thing goes even with my own experience with marrying a person from other caste, or like, my parents' family, like within the family, the autonomy in Indian context certainly exists, not in an individualistic way, as we all know and very well aware, but I think it's more about the wrestling with the tensions. It's an everyday negotiations, and I think that's where agency exists. And I think the answer goes back, I think this is where I think of how do we move or shift from, I wouldn't call it a binary, not active patient and passive patient. I hope I don't see it as a binary or like it's a two extreme ends, but definitely a spectrum. I think it's interesting that you brought in the dead patient. I mean, it's a sad situation. I think many of you would have experiences and also have heard, as you said, like many stories of where do we even see a patient when there is a person is dead, and especially because of the larger corporatized and where you don't have trust. I think one of the key things which I pick up what Amar was trying to say is about the human rights and the aspects of bioethics and ethics within the larger medical faculty. I mean, the larger, the medical ethics space or the larger medical space is how do we cultivate trust when there is huge mistrust already, like the trust is already precarious. Then a patient needs to really critically ask questions, which I think that's where you were also trying to say, and that's where the reform also would end up with. But now my question is, given the way the current climate and the larger 10 years or the way the larger society where asking question to state or to the doctor or to the parents has been increasingly like romanticized version of like, let's go back to the traditional values, hold on to that, I mean, this is my understanding, like let's hold on to this core values which we have as Indians and blindly trust a doctor or listen to the elders. I think this is like a key recurring theme across. And that means we would end up going back to the question of being a passive patient. So reading your work and listening to you, Amar, and having engaged with you earlier, is my question to you both now, listening to you after, is like, how do we, given the exclusionary logic the systems work? I mean, what Angela was, the way we talk about is like the masters, the system works the way it is working because it's how it is, designed. It's not a flaw, it's designed that way. So then how do we resist? Because I remember Amar was talking about we need to bring public and there should be a resistance. But people who have been exhausted, like, people who have been humiliated, shamed, and constantly been disregarded every day, after a point, where do we have the energy? I'm not saying the resistance doesn't exist. There is a huge self-respect movement. There has been an ongoing, the conversations within patients' rights organizations, but it's hard for people who, then the question for me is about the privilege. The person who is with privilege, that is medical professionals. I think that's where ethics education plays a role, but then sometimes I feel it doesn't play any role. So now question for you both is like, having in this space, what do you think patients or the larger public should be doing in order to bring a larger moral outrage in the society? Sorry.
Okay, maybe a very quick answer to this is, I'm glad you asked that. Sorry?
Oh, thanks,
To use the example of education again, the difference between education and being an active student, training student to critically think and question the teacher, the reason why it's different from that of the doctors is that I get to meet a doctor for 5 minutes, but I have a student for 3 months to train that student. And I train the student over 3 months over a course to make her think and ask me question back. And I produce an environment, a safe space for critical thinking. With doctor, I'm waiting. I'm very glad that the doctor is seeing me. I have 3 minutes. I'm able to say something and come out, right? So where does this training of autonomy, see, the autonomy is not given. And I just can't say, I have a right to question you. No. That may be there, and that's not even about tradition. And the point is, how am I training the society to be able to question those who are in hierarchically superior? And that's got the same training you do to question politicians or upper caste and upper class is the same training you need for this. And what I find very interesting is that at least not among the people who have been really oppressed in various ways, who enter these systems, especially in government hospitals like you have described, in the middle class, upper middle class, you can already see there's a very good reaction. One is a Google doctor, which you yourself mentioned. Now I know in so many places, I'm sure many of us have experienced, the real doctors whom we go to now are the pharmacists. And the diagnostic labs. Because I know people who don't go to the doctor to go get their blood, to see cholesterol or whatever, blood sugar. Because everybody is worried about sugar in India, I think. So they all go to the diagnostic lab directly because it's also cheaper. Otherwise, the diagnostic lab are paying the doctors, that extra 20%. So these fellows, they go pay that money, and then you take it to the pharmacist who looks at the numbers, the same thing which the doctor does for $1,000. Looks at the numbers and produces. You know what it has done? It has produced a large number of people. So this raises very important questions. So I think pushing this, what you have done to break up that question of medical into more finer domains. Because if you look at what we know even around the world, globally, the medicine which, for example, on which American pharma has really made its most money is not these cancer medicines, these very exotic. It's antacid apparently is the highest selling drug. And the point is that very basic health life, what do they call this? The health, this ordinary life diseases, something they call it. Lifestyle problems, which are not really about very deep medical science. Those medicines are the ones which are driving a large amount of medicine. So I think the way in which I can question a person who gives aluminum antacid tablets for me versus the way I question a cancer doctor are two different things. And that differences between the nature of practice of medicine may be one useful point. Because we can do this at a much easier level, and that is happening, as I said, with all these pharmacists acting as doctors and so on. But the larger question of, therefore, building this, I must tell you that I think, at least even among different class things that you have seen, there is, at one level, a suspicion. I mean, especially the little more so-called liberated class, they seem to feel that they can question doctors. Today in Bangalore, one of the biggest problems has been patients beating up doctors, which is also terrible to see. So you have had to have police protection for doctors and so on. And that's really ridiculous to do that. But on the other hand, people who have been socially oppressed still take it into the medical domain, because that position of liberation has not come. And finally, the third point in all this, which again is, I think it's impossible to talk of medicine today without insurance. Right, that corporatization of that larger capital, medical capital, which defines what medicine is. A lot of this kind of questions about this passivity is also terribly dictated by insurance at various levels. So, I mean, I think what you've done is to open up these points, and one has to, go through in each one of them to do in one of. No, the insurance thing has become so, in the sense of passivity, in the sense that there are people who get. I'll give you one example, which I'm sure you know of. This is very common, by the way, in the insurance. You go to your doctor and they tell you, you say, I have some stomach upset or something. The insurance will only pay if you get one day you have to be in the hospital, right? So there are people who will stay in the hospital for a night because that's only when insurance will pay for it. I mean, insurance is one of the most damaging things which has happened to Indian medicine. Most damaging. And the people who are able to afford insurance are a very small fraction of the society. And that has allowed them, so the first thing you go to meet a doctor, they first ask you, in any of these hospitals, do you have insurance? Then only we will see what, then you have different rates for the insurance. The insurance guys knows that the rate for you with insurance is different than for the other patients who come. And this whole, the glove, hand in glove with that, has led to very deep ethical problems, particularly in the Indian context, because so many of the people who go into government hospitals, who can't access doctors in hospitals, what do? It's really a terrible thing which is happening with these larger hospitals and stuff.
No, thank you, Sundar. And I think briefly to touch on how the patients who go and access government hospital, right? The idea of free, which also is, I think in the conversations in Indian, whether it's a health policy or programs, I think giving free is something stripping away one's dignity, which is it's a right? As a patient, it's a right for us to go and access government hospital, but the quality is another whole conversation, because some of them would actually prefer government hospital because of the quality. But at the same time, you need to endure this, completely dehumanizing experience from the larger architecture, the structures, but at the same time, the whole, the waiting period in itself is something very dehumanizing. Now, I think another question which you raised, and I think which I was wondering about with medical professionals, is once they're experts, of course, because they know better, because the idea of the epistemic authority which they come because of their expertise of the human body. Then the question for me is about the lived experiences of patients, which is not really accounted and valued within the medical ethics space, and even within the larger questions. When I can't imagine in this book, if a doctor would read this is anecdotal. It's just few experiences you're just compiling. That's kind of a dismissal of lived experiences of patients is something which I think is also part of the larger problem within this situation which we live in right now. I would see it as. But what do you think, Amar, about this? Sorry. Do you about the lived experiences of patients, how it is discounted within the medical curriculum, or?
Well, I don't know much. Things are so complex the way you were articulating. I like something very simple. My mind works like that in human rights. We just see that what are the rights and how to get them. And then I'm becoming old, so I keep remembering history. That what happened kind of stuff. And I think what you were talking about, the families and the traditions and the lack of resistance and rebellion by the youngsters in the family. What reminded me was, my past, that what I saw in 1960s and 70s, where a section of middle class, put up a lot of resistance. And the first thing that I did, I remember as an adolescent, is to rebel against my parents, And it was considered to be very normal. I don't see it now. I find that the youngsters believe that, to be part of the family, to be proud of the family, to be proud of the traditions and the community they come from, is something to be cherished, which in my time we thought that all those things were real shackle on our autonomy and what we wanted to do in life, right? And so we used to have a lot of love within the members of the family, but we used to fight equally and rebel against each other. So that's one thing that came to my mind, that when we are talking about the passive patient here and the accepting the kind of power relationship that is existing, then we have to keep thinking about that, why people are not resisting, and if they are resisting, how they are resisting, what is the way of doing it, and is it effective, right? And why there is no rebellion as such. Huh? Two things came to my mind, because he was also talking about medical education. I don't go into the details of it, because we have debated a lot in the medical friend circle about how things have happened, the doctors losing the human touch, and then they are more interested in looking at your x-rays and scan results and the laboratory results rather than touching you. All those things are there. But what I saw in the things happening in 80s and 90s in Western India and in Northern India, where the whole rebellious tradition of the students, including medical students. I remember in Gujarat, we shut down medical colleges for 6 months during the student rebellion in mid-1970s. And we didn't care about a dean sitting there or a professor sitting there, and we will go there and challenge them, right? They were young students, and I was in the first MBBS at the time. And in 80s, I find that the things completely change, where suddenly you find the reservation becomes a big issue, right? Suddenly you find that the caste of each one is very important. You have to find out who is in the quota and who is not in the quota. And these are government medical colleges I'm talking about. And in mid-80s, there is some resistance when the private thing comes up, where the reservation is for the rich, right? And there were rebellious, junior doctors who went on strike against it and said that, no, we will not allow it. And in Maharashtra, they had a strike of 28 days, the Maharashtra Medical Association of Junior Doctors. So with all this Sanjay Nagral and all these people that you know of now in medical ethics and human rights, the doctors, they all come from that struggle, So this was the area where you find that on the one hand, the new things were coming, which were more conservative and traditional. On the other hand, there was some resistance by some people. By 90s, it entirely dissipates. I haven't seen that thereafter. Anything of significance happening. And so I keep wondering, I understand the need for micro-resistance and having a kind of a war of positions, and you gradually erode them. But that will work only if we are able to see the trajectory. And I become very pessimistic oftentimes, but I think youngsters are able to see the trajectory, that they have to bring it out of it, and then learn to question what is happening there. Within medicine, as I said, it is going to be extremely difficult. The simple reason is that people now go to medicine not to solve, but they go to medicine in order to be part of the power structure, right? There will be few, there are always rebels within that who will go in the villages and who do the community health works, and that is where I belong to. But I know that the mainstream, we have 700 medical schools. We are talking about a huge number of 100,000 students coming out every year, as doctors. And so it's a massive. And so if you are looking at the trajectory, historical trajectory where we are going, and then you'll have to appreciate that the micro changes is not sufficient, but there needs to be something which is stronger than that. The last point that I can make is from the political perspective, is that in no country, the larger changes in the health system or any system has come about without that subsystem or the issue becoming political. And in India, one of the tragedies is that education is political, food is political, but health is not political. Look at any political party. Do they really use as their health program as one of the vote-catching program? In US, if you don't have a right position on the issue of health, you lose election. Same thing will happen in Europe. If you don't have a right position where people respond to you. In India, no election is lost because the kind of position that you take. The health is still part of the patronage system of the old time, where you have those, insurance that government goes and buys from the private sector and doles it out as some kind of buying of the war. So to that extent, it has happened in last 15 years, with the more and more, first UPA and now the NDA government. Earlier as a part of the liberalization with human face, and now as a part of, doing the social engineering. But it is happening. But still, it is not a political issue. People are not questioning it. That is it really helping you, right? So to my understanding, the non-entry of the people who matter and who go and rebel within the medical system is a very, very serious concern. People like me, who did not have money and still became doctor, those kind of examples are hardly any. Even to get schooling, you require lakhs of rupees every year. And if you want to have MBBS, you have to have crores of rupees. And if you have, want to become super specialist, it will be several crores of rupees. The totally different ball game today that I see. And that makes me angry as well as depressed that can we think about how do you, as a teacher, that when we teach, if there are 30 people sitting there, ultimately your message may reach only to 2 people who may take the flag forward. I don't know how you are seeing it as but when you have medical classes where 150 students are sitting and then you are giving a lecture, and that is how the medical schools are nowadays, I don't know what is reaching them. And whether we are able to, will be able to sensitize at that level. I think it's not that I want to continue doing reform work in the medical system. I am there as a medical ethicist, as a part of the community health movement and all kind of stuff. But I have no illusion that this is going to change the society. But I have a lot of illusions still from the historical evidence that people who are sitting here who are not doctors, but who are the ones who are mistreated in the system, if they don't speak, nothing is going to happen, to my understanding. Doctors will not become sensitized. They will not change the way medical education is given. And that makes me a bit pessimistic about it. But yes, as a researcher, you do go into the details of it and all. I used to do it once upon a time, doing micro research. But nowadays, my patience, whereas the age is the factor that I'm not able to concentrate on those minute details as much as one should be doing. I look at the larger picture and I find it frightening.
I just want to quick come back to your thing. I think, what do we do? One is, of course, teaching, right? So we tried, for example, medical humanities course have all been utter flops. Medical ethics course, trying to teach them there. I remember after we tried to do it among the doctors there, after one round of it, they said, we don't want people from humanities teaching this. They want only doctors to teach that. And then they have reduced all of medical ethics to a checklist. So you do a checklist. So they don't want all this. They think we don't know. They don't and they don't like anybody from social science humanities to enter the department only. So okay, I can grant that. But what can we as social scientists do? There is one path, which is we have to recognize that words have power. We don't have anything else. Well, we write too much in words and all. Great. So let's take our weakness as power. The words have power because they produce concepts. Passive patient is a very good example. We've been using the word passive patient. It's so much in the vocabulary. People start interpreting patients as passive. The way we can get back at the medical community as social scientists is to now produce the meaningful idea of a term called passive doctors. If you want passive patients and active patients, our point is to say passive doctors are those who have absolutely no idea of social structures, who don't know how to deal with patients who come into their offices. And if we want passive patients to become active patients, we need to make passive doctors active doctors. Whenever we talk of the doctors community, we have to call them passive doctors. And they're going to get irritated after some time. And then they'll say, no, because that goes back to their fundamental sense of what they, their God figure, right? So we have to keep calling them, referring to them, writing about them as passive doctors who don't know. They may know what medicine is, they don't know anything about society. And if they don't know that, then they cannot be good doctors. See, within the medical community, they can feel very happy, but they know when they engage in society, we are calling them passive. How are they going to? They'll then have a conference. Somebody, when doctor will write a book, how to be an active doctor,
Just to very quick point. One thing is about the trust, the trust in medical profession, trust in medical science, because, I found that in bioethics in last 20 years in India, the trust is talked a lot about, which was very a novelty to me. That's when Vijay Gopichandran did his PhD on trust, and I kept questioning him. I said, why should I trust? And in all the issues about vaccine and vaccine hesitancies why should we trust vaccine? Unless that I am able to verify that my trust is not being misused, And that verification needs to be available to everybody. If that is not available, you have to call them out. As you are saying that you call them passive doctors, you call them any other name that you would like to do, but yes, that is required to be done. And I don't know whether they will really change because of that, but because they are also very smart. And I see that when I teach bioethics, and even when I teach medical regulation, I used to ask doctors that, why are you here? I said, is it necessary for you to come and learn ethics? Because you had in MBBS, in forensic medicine, you had few classes and all. But they all will say, yes, it is extremely important, and Then I said, well, it is important because it's like, anybody who's a thief, who is a criminal, needs to know law so that you can avoid the law, isn't it? You need to learn ethics because you don't want to get caught while doing unethical stuff. And that's one of the reasons when we were interacting with the government and on the ethics training, one of the things that they kept arguing is that we don't want all these theories and principles and that kind of stuff, doctor-patient relationship models and those kind of stuff. What we need is, tell us what is the best way to communicate so that patient can have trust in us, And so communication, that's why in the government, when it came out with humanities, you will find that communication was central to it. He said, you are getting bad press because your PR is bad, So have good public relationship. And so that's what I think whole management is about, whole politics is about today, and that's what I think doctors also believe. So I hope, even when you call them out, how they will turn around and use the same thing to their advantage, as they are doing it for ethics and other things, yeah.
Oh, there's so many threads, but I think we will continue to talk, but I think we are running out of time and we have a panel discussion. So again, thank you so much, Sundar and Amar, for completely engaging with us, and I'm very thankful for this. Thank you.
Is it working? Yeah. All right, so we will just begin, right? Just dive into it. So thank you for staying back, and thank you for a wonderful panel. So much to learn. Also because I work at the intersection of anthropology and philosophy, so I see that disciplinary, tussle that we have at times, and how people would want to put you, Priya, into a discipline. that, does it look like medical anthropology or does it look like a feminist philosophical work? Is it? And how to navigate that? So that kind of questions, we all keep getting. And it was a very brilliant discussion about the epistemic authority. Who is the knower? Does knowledge really empower you or does it silence you? And then the question of ethics. So moving beyond Kantian ethics, for example, because my work is on care ethics. So I think, relationships become very important. But what do we do when the family or the space where we are navigating relationships themselves become difficult to navigate, or you cannot, because that's not, again, a very, always a rosy, cozy space. So we had a lot, a lot of good discussion. So now moving ahead, we have 3 eminent people with us. All right, yeah. All right, I think Sylvia had a call. So let's see. Once she comes back from the call. So, but in the meantime, I will welcome Dr. Meena Putturaj, who is a faculty and Wellcome Trust India Alliance Fellow at the Institute of Public Health, Bengaluru. She works at the intersection of clinical nursing practice, teaching, and health policy and systems research. And she's leading a participatory action project that aims to build inclusive governance for tribal health in India. So welcome, Dr. Meena. Then we have Dr. S.V. Joga Rao, who leads Legalexcel, a law firm of advocates, solicitors, and healthcare consultants. And he has been the founding faculty member and was till recently a visiting faculty at National Law School of India, University of Bengaluru, which he isn't now, he tells me. And he is deeply passionate about issues and challenges emanating in the discipline of healthcare, ethics, and law. And then I'll again welcome Supriya as well on the stage so that we can have a more, conversational panel. Comes. And then when Sylvia comes in, and if she comes in, so we were hoping to have Dr. Sylvia Karpagam as well with us, who is a public health doctor and researcher, and who works a lot at the intersection of nutrition, caste, health equity, and at SABC. We actually recently had her on a panel. So I hope if at all, she gets free from her call, she can be here. So yeah, I will just quickly begin firstly, and I will park my observations to the end if at all we have time. Otherwise, of course, in the course of conversation, it will keep coming in because my work has been on surrogacy. So, and the law around surrogacy. So it is kind of traverses law, medicine, and the idea of who's the knower. Because the idea is that a surrogate was always exploited, and hence, let's get a law to kind of save her. So that, like rescuing and all that, I could really resonate with your work, but I'll park that for the end if at all we have time, but I'll open it and I'll start with you, Dr. Meena. What are your reflections on the book? Also because you work with the tribal community and you work with governance reforms. So what would you want to say about the book and about your own experiences on the ground?
Sure. Thank you very much for this opportunity. Thank you, everyone. So first of all, I would like to congratulate Supriya for this wonderful book, because already I see this as an act of resistance, disclosing the implicit power, how this idea of passive patient culture is constructed. So I really appreciate that. Before I make any statements or my perspectives on justice, relationship between doctor-patient and all that, I would like to say that I am a nurse by background, because my professional experience, my personal experience, have also shaped and it is continue to evolve because of my professional work with engagement with communities, community mobilization and all that. So there are several themes that actually resonated from your book. One is that the medical power, the role of medical power, because I also kind of explored how, even though we say we have consumerism, people have now consumer rights, that is kind of promoting agency for the care-seeking individuals. I prefer to use the word care-seeking individuals than patient, because the term patient itself is very disempowering. If I go to a hospital for vaccination, there I am not a patient. Pregnancy is not a medical illness. So why do you construct words of power, as Sundar says? So instead of patient, maybe the better terminology we are yet to find, but then I prefer the term care-seeking individual. So especially what I explored, what I understood is that how the medical power especially is shaping the grievance redressal processes. By grievance redressal processes, what I mean, for example, you have patient rights. right to informed consent, right to confidentiality, right to dignified care, so on and so forth. But then, if you have all these rights, but if you don't have the right to grievance redressal, then it's like a social declaration. We are not sure whether these rights will be enforced or not enforced. If violated, then what we do? There is no accountability. So from that perspective, the right to grievance redressal is very, very important. But then I kind of analyzed in my work how it is so difficult to exercise this idea called right to grievance redressal. So how, especially medical power, how medical power makes it very difficult for people to even raise a complaint. For minor things, we don't raise a complaint unless it is very serious, because, it takes a toll on the care-seeking individual, their families, because they have to invest a lot of time, energy, resources. Like, it can take years also to resolve those complaints. It's very exhausting, mentally, physically, emotionally draining experience. And in those processes, the medical power, they've given privileges. They are in a very advantageous position. So it becomes extremely difficult to prove something to the judiciary that the violation has happened or not. How those things, how implicitly, how in cunning ways, I should say, how the medical power is working. What are the workings of medical power in these processes? And for instance, I could share this experience working with grassroots movements in one of the districts in Karnataka. So they were trying to raise a complaint against one doctor working in a public hospital on unwanted hysterectomies, unwanted removal of uterus. Even to raise one complaint against one single doctor, the whole village has to rally. They have to protest, they have to engage with the media. So, who is deciding what is a valid complaint? It is again the medical body, right? This is valid for investigation, this is not worthy of investigation. It's right from that stage, and you can imagine the other next steps, what kind of power they can wield in the processes. And then the committees that were set up to investigate these unwanted allegations on unwanted hysterectomies, it is all medical bodies, they're all doctors. If you see patient rights violations, I don't think it's purely a clinical issue. It's a social issue. There are non-clinical aspects to patient rights violations. So if that is the case, then why only doctors are dealing with grievance redressal? Why they are rallying for self-regulation? There should be external regulation. There should be involvement of non-medical people in the governance spaces that deal with grievance redressal. Because there are non-clinical aspects to patient rights violations. But they don't accept that. Doctors don't agree with that external regulation. We are doing fine. We have self-regulation. We have medical bodies. We have ethics. So this is what I explored. And they have a lot of political clout, social status, all that. Even they use discursively, they manipulate. Like, for instance, in this case, when the grassroots movements, they were problematizing unwanted removal of uterus as an issue of justice, issue of ethics. The medical bodies, they were problematizing as an issue of, clinical incompetency, how they are reducing the problem. So they have, in multiple sites, they can wield power. This book actually gives a very grim picture about, but then that's the power of critical theory, I would say. Of course, it is negative about the current situation, but it also instills hope to identify the entry points, to identify the possibilities for transformation. That way, this book is not so negative. It actually opens up areas to think about social transformation in the healthcare service space. And we spoke a lot about how this doctor-patient relationship is so exploitative, right? But we should also think a little bit critically reflect about how the state is facilitating for this kind of exploitation to continue, right? By having weak regulations. We have Clinical Establishment Act, we have Private Medical Establishments Acts, there are legislations to regulate the conduct of health professionals. But I also analyzed these policies where these patient rights provisions are embedded. Then I realized none of the policies, especially very few, like maybe Consumer Protection Act use the word rights, consumer rights, and these are your, clearly articulate, these are your rights. But if you see the legislations concerning health professional conduct, so there, nowhere they use the term rights, nowhere they use the term dignity, right? Explicitly. For example, in Karnataka, we have Karnataka Private Medical Establishment Act. The preamble of this act doesn't start with, in order to preserve the dignity of care-seeking individuals, we have this act. It says, in order to promote the quality of care. They are using terms like quality of care all the time, consumerism all the time. These are the efforts, using powers, using discourses to undermine. They really don't want people to hear about the word rights. At the hospital level also, there are efforts, conscious efforts being undertaken to keep you away from hearing or seeing rights. Small example. You would have gone to NABH accredited hospital, which says that quality assured in these hospitals. So that's the myth, actually. If you go and see the patient rights charter, a simple charter, you just observe where they position. It'll be hanged in a place where it is not really visible. Tokenistically, these practices are done, right? And if you closely observe, patient rights will be there, patient responsibilities will be there. The number of rights will be less than the number of responsibilities. So these are the indirect ways of constructing passivity in the patient culture. So that is one. The other example is, there are pamphlets out there. We are made to know about our patient rights, to learn from the healthcare professionals. There is a conflict of interest. How would they tell about rights to you? So the idea of rights is kept very hidden, unspoken in the healthcare setting. So I would say that the idea of rights, the conversations about rights should start outside the hospitals. Like, for instance, schools. In your formative years of education, critical thinking, raising this civic consciousness, that should happen, I feel. I think I'm taking too much time.
No. So I would want to then also get back to Supriya and join it with something that you are a nurse, right? And if you look at our medical industrial complex, the nurses themselves are navigating the power hierarchy as opposed to doctors. So one of the strands that I work on is midwifery. And again, so we were trying to look at critical midwifery, and then the position of nurses also become very important. You somewhere mentioned that there are anecdotes of nurses telling you, but we are just trying to, hum to samjha rahe, we are trying to tell them that this is the right thing to do. We have to tell them like this. Only then they understand. And I understand that nurses themselves are kind of, are passive at times in the system, as opposed to the doctors. So can you speak a bit about those anecdotes, and then maybe Dr. Meena can reflect on that?
Thanks. Thank you so much. I think the work which you have been doing, Meena, it's like so brilliant ways of showing what complaint literature. I think the Sara Ahmed's work beautifully shows, and what you're actually doing to unpack the health structures and how healthcare system through the eyes of complaints. Because when a person complains, you have become a problem. And I think that's what you're trying to show, how health systems brings in the conversation, how patients, you already have been experiencing so much of pain and exhaustion, and then on top of it, you need to now prove. Because evidence is what matters for the medicine again, right? The conversation of even complaint becomes such a big conversation in itself, like to prove that. So thank you for that work, and the way you trying to unpack that. The question around which, Priya, which you were trying to, connect to the larger ways of nurse, being the mediator, I think the way, so it depends on who is this person? I mean, the sense of which hospital the nurse is, and where the person is coming from, that is a social background, and the training also matters. Like, for example, some of the nurses who are trained in a certain colleges would be having much more assertiveness, and also the tie-up, the kind of apprenticeship and the work which they do plays a huge role in what kind of an assertiveness they can or they could navigate within the power asymmetry or sometimes the power relationship. So, for example, I think the examples which I bring in the book is also very often nurses in private hospital, they play the role of consumer. I think you mentioned about that. They're the consumer, right? They're entitled to a certain kind of a care, which is a quality of care, but not a dignified care. So you can't ask questions. So what nurse does, I think this is what I was trying to understand, is the nurse become the mediator between the doctor and the patient or the family member. Very often, often in the private hospital, the patient and family members, they end up demanding, they immediately go to nurse, because that's where, who are the accessible, not doctors, because they come for rounds, right? They come very once in a while, especially if you're on the surgery, the time period and all that. So nurse then becomes a person, hey, I'm going to be, I try to humanize the care, but also I become a mediator to listen to the doctor. I think that's something which I noticed or observed. But in government hospital, it's slightly a different kind of a degree and a dynamic which plays in, where the doctor certainly comes in a very rare, like in the rounds. I'm sure everyone who knows government hospital, we know the parade. We know the time, how the doctors enter and how the nurses play the role, the tailing, whether it's not just patients, but also the nurses tail behind the government hospital doctors, right? There, then the family members, the nurse actually very often, at least this is what I noticed in Chennai hospital when I was looking at in the government hospital, nurses has a lot more power. Like even ayahs have a power, but also nurses play a very huge role, because the way the award is set up, where the nurse sits, it depends on what kind of a nurse, is a staff head nurse or not. They sit right in middle of the ward of all the 20 beds, and they play a role of actually disciplining the family members and the way they access the ward and the architecture in itself. So then the question for me, the thinking about is, the way we think about dignified care and what nurse plays is very often the mediator, but also sometimes they actively also oppress. Depends on which hospital settings, definitely. But again, in a rural area, it's totally a different ball game. I think the conversation becomes much more, I think we need to talk more and expand, listen to, yeah.
Okay, I think my nursing identity is being so much used here. But then I just want to share that now I'm not practicing as a nurse. I ventured into public health, and I also showed that even a nurse can analyze policies and yeah. So it's open to anybody. Anybody can do anything. So I really not very comfortable reflecting how nurses are acting like facilitators or mediators. But the point is, nurses should not become like reflecting or become the voice of hospital management. That is very, very important. Even when, see, the tragedy of nursing is when they themselves are suffering and exploited, and you have expected them to be the patient advocate. That's the irony. Like, okay, you undergo all sufferings, but you talk about the welfare of the other. Right? All this problem comes, I think, because the conceptualization of rights, you have women's rights, rights of children, mental health rights, you're kind of fragmenting. So that also kind of dilutes the power of solidarity, collectivism. Even that is important. At the end of the day, it's about citizen. It's about a person. Of course, there are specific characteristics to each social group we need to cater to, but at the end of the day, you're a person. There is an inherent worth for you, and that should be respected. How do we build that kind of agency? That is missing. That's why I say even the term patient rights is problematic. Even the term consumer rights is problematic, because consumer rights says the responsibility is on you, even to access care. It's your headache to mobilize resources to fund your health care, to learn about your rights. That is it. For marginalized communities, it's going to be burdensome, even more devastating, I would say. So that's why maybe we should promote this idea called citizen rights. In the hospital setting, citizen rights matter. In the police station, citizen rights matter. In the school, citizen rights matter. What is the state-citizen relationship? That we need to unpack little more in the healthcare service delivery space, I believe. And health professional training, I think it's important that we promote rights-based education in health professional training, be it for nurses, be it for doctors. That is not happening. We are kind of threatening, creating a fear among the young budding professionals. If you don't do this, you'll end up in jail. So why unnecessary fear? You talk about rights, you talk about dignity. Why that is so important in your professional practice? So these are the systemic ways of changing the reality.
No, but also very interestingly, how, like you have once, and your anecdotes tell a very different story about the nurse and the power, but we also know how nurses themselves in the system are at times are suffering in the system. So how these identities are not like the argument that you make are not fixed. So the activeness or the passivity is not fixed. It's like on a spectrum. And again, care is something which is again central, be it the relationships, how we look at the identities, or how we trying to change the very language. And language is something again that you talk about in the book. Now coming to Dr. Rao, so around the legal discourse, so what this book does is taking us both into the law and the medicine. And the right, when we talk about rights, patients' rights, we are actually talking about how we can use law to then question if those rights are not there, and also to demand rights. So, Dr. Rao, when I was looking at the acknowledgement also, you've had a great impact on Supriya's journey and the internship that she did with you, and also the case that you actually eventually work with, Sameera Kohli case, is being pointed out by Dr. Rao. So, your reflections on the book.
Sure. Good evening, friends. Before I share my views about the book, I want to file 2 caveat applications as a lawyer. First application is, I have not read the book completely. I have read only 2 chapters. The chapter which is more related to my kind of work and knowledge, namely passive patient in Indian legal discourse. That I have read multiple times. Second caveat, I belong to a league of black letter lawyers where interface of humanities, philosophy, ethics, etc. matter very least. By training, by qualification, by experience, we are not exposed to that. And let me tell you honestly, majority of the judges in the High Court and Supreme Court are also not exposed to that. Therefore, I am literally a novice to your methodology, critical philosophical ethnography. I don't know. But when I read the chapter, I understood Supriya, whom I know 13 years ago, and Supriya of today, unbelievable persona in terms of writing, the chapter. In fact, according to me, as a professor, as an author, and as a practitioner, I think any writing will get its credibility if the writing is provocative. And I think your second chapter is highly provocative. That's where I am going to talk about it. These are the 2 caveats. To begin with, power, paternalism, leading to passive patient is an established fact, historical and contextual. The way the equations, dynamics operate, I can give you one small example. Many of us, we talk about informed consent. My dear friends, informed consent, Honorable Supreme Court judgment, etc., etc. My own relative told me the patient is to be subjected to surgery, maybe next day morning or so. Sheaf of papers a nurse has brought and asked the person to sign. The person asked, what are they? She said, you will get to know if you sign. And he has signed, and somebody came, some explanation, who is that person, etc. This is. I am not generalizing, but I am saying majority of them, this is the way in which the informed consent in courts, that's what happens in practice. Therefore, when Mr. Sundar and Dr. Amar Jesani mentioned about questioning, I was just wondering, questioning comes later. First of all, the person need to understand what a doctor is speaking. The medical jargon. In fact, as a law professor teaching healthcare law, there are so many words and jargon which we don't understand. Medical dictionary is always with us. Therefore, informed consent in that way. Now, coming to the second chapter, why did I say it is highly provocative? Let me bring it to your notice one aspect, or rather pose a question. Did you meet Justice R.V. Ravindran? You know who is he? No. Justice R.V. Ravindran is the Honorable Supreme Court Justice who rendered the judgment in Samira Kohli. I can tell you, I met him several times. He is one of the, in terms of not only popular perception, even my own personal understanding, a scholarly judge. The judgment, etc., is something many people. But when it comes to, though the interplay we don't understand, certain things are quite obvious from his judgment. You have mentioned in your book also. For example, Honorable Justice Ravindran says, no, you are already 44 years and undergoing hysterectomy at this age. There is no scope for reproductivity. In such circumstances, it is a fair option. Having said, Honorable Justice Ravindran gives compensation of rupees 25,000 for undertaking a surgery for which she did not consent. I think that shows the kind of medical paternalism endorsed by Honorable Supreme Court. Having said, I must tell you, I have great respect for him. My only concern is, many a time, please correct me if I am wrong, many a time we write, we say, may not be actually thinking about the outcome of our writing. Sometimes it may happen. To bring that aspect, you brought out excellent analysis between the Bolam test UK approach and Montgomery American the informed consent. And according to your analysis, which I fully agree, but one aspect I differ with you. Page number 54, where you mentioned Supreme Court in Samira Kohli, while using the word legal and valid consent, opted to endorse UK approach, but openly saying they are not for Montgomery in the light of the existing realities, etc. In my opinion, this is what I taught for several years, 2008 onwards. Even today, I hold that position. Justice Ravindran, no doubt, specifically said Montgomery is not endorsing for various reasons. I am really not convinced the reasons for not applying that standard, which he feels highly stringent standard. In our context, it's not necessary. Either sociologically or some other science, etc., the reasoning is not really, not convinced me. Having said, why did he say legal and valid consent? What he meant after reading the judgment is not only Bolam test endorsement, but what he meant is the person must be competent and conscious. In order to say that, he used that phrase, legal and valid. But if we look into the entire judgment, I am of the opinion Justice Ravindran did do justice to informed consent. You brought out by saying informed consent is not given its recognition. In my opinion, Justice Ravindran gave. For the simple reason, on page number such and such, he mentions very clearly what is that information the doctor is expected to share with the patient so that the patient will be able to decide whether to say yes or no to the proposed surgical intervention, which to my mind he did. But it requires to be elaborated, etc. I do not know, maybe for his own, because of his own wisdom, whatever he felt. But otherwise, only one sentence. When I was reading your chapter and a couple of afterward, I have read with a lot of passion. In fact, more than you, I was very passionate, I must tell you. Because how do we really bring a change? I think that is the most important thing. And your preface, everything I have read. What I felt was, I know doctors don't agree, humanities professor to teach them humanities to doctors. But medicine cannot be a mere science. Medicine must be understood as a part of larger social science. Unless and until that comes, either lawyers or judges, very honestly, we are all black letter law. You know what does it mean? We read the provision, put the components, essential ingredients, 1, 2, 3, 4, and say, this is what happened. I don't think law in terms of black letter is to be. I think you read. No doubt my association as a National Law School professor did teach me some kind of thing, but that's just peripheral. I don't think I can be even 1/10 of Supriya Subramani. I am not joking, Supriya, that's a fact. The kind of work, the kind of learning, the kind of, you are writing. A day before yesterday onwards with my family, saying about Supriya, writing this, that. I said each word, you need to refer dictionary. And the same girl, the kind of problem she has faced in English language, almost 20 years ago. The same girl is what this outcome. Therefore, only one sentence. I think you need to, in your future work, be inclusive, where doctors also need to be consulted. And judges who write judgments need to be consulted. In fact, today's panel discussion, he is the right person to launch your book. Justice Ravindran. You know why? But for Justice Ravindran judgment, your entire chapter is not there. Second chapter, no. In fact, that is where that judgment is also highly provocative. Certain things, they are very, particularly about hysterectomy, etc. That's not the way to really. That's where it comes from power. The kind of, no, I'm doing the best for you, etc. I think this is what I feel. And a couple of other things are also, they are too technical from legal point of view. That I'm sure we will share through email, etc. Thank you.
Thank you so much, Dr. Rao. I think this journey, first of all, as a writer and as a student that you've made, because he's seen you as an intern, and then now I think it's a great compliment that everyone is then talking about the writing bit, which you also kind of acknowledge in the beginning itself, how that has been seen as a marker of intellect at times. If you're not able to speak or write in a certain way, especially when you are like in a department like Humanities and Social Sciences. I come from IIT Bombay, similar Department of Humanities and Social Sciences. She was in IIT Madras, so I understand the kind of spaces we have to navigate for those of us for whom English is not the first language, or who might not have come from really, the big places. But of course, we do not share the same positionality in terms of caste. And we've had those discussions amongst us, but we share the politics. So it's a great compliment about the journey that you've made. And also, I just wanted to, just for the audience, can you just, in a very brief, tell about the Sameera Kohli case and how that becomes important? Yeah.
Thank you. Thank you so much. I have basically I learned to understand law and legal judgments through you. So I really, I'm very thankful for your guidance over the years. And at the same time, the way I learned is through you putting me in a case and allowed me to get in touch with the patients who went through this legal procedure. So that allowed me to think much more, rather than working through the legal lens, what I try to understand is by talking to patients who are going through this process, the legal process allowed me what this informed consent is for whom, right? That was a question which was my PhD work. The title of my PhD was Essence of Informed Consent. And I gave up on it by the end of, and in this book, basically, I tried to show what this is trying to do and who is this patient. I think that's where I end with. So the informed consent, going back to what Priya was also saying, is that Sameera Kohli case, which Joga sir actually gave me, this is the case you should read. This is what you need to unpack. And the more I started reading and analyzing the legal judgments, for me, I'm not a lawyer. I'm not a legal person who wants to look at the provisions or what it means. But then I understood one key thing is what is the significance, the precedent-setting case which plays a role in understanding the larger legal frameworks and the larger legal norms which plays in. And in this case, basically, this is my quick summary of the case. Please correct me if you think I'm getting it wrong. Is that Samira Kohli, Samira is a woman who was an unmarried 44 years old woman who went to a doctor with heavy, blood. I mean, there was a lot of bleeding. So she went to the doctor, and it's a woman doctor who actually she went to. And this person basically said, oh, let's get the diagnosis done, laparoscopy, let's do it, right? And this is a multiple encounters this person had, and then on one of the encounter, the person said, okay, let's get the diagnosis done. And during when she was unconscious, the doctor did a hysterectomy without asking the patient, but got a consent from her mother. So that's a key thing which the whole judgment was trying to unpack. Who gets to consent? And then the judgment, as you rightly said, so that it's about finally the leaning, back and forth of a lot of analysis, whether should we go for US law or whether should we lean towards UK, even given the understanding of how the legal structure within India is very much UK based, or the colonial structure is very in place. Then the question becomes, at least for me as a social researcher and looking at the lived experiences, a 44-year-old woman, when they go to the doctor, and the analysis of both by the judge and the doctor, the way they try to bring in the narratives, is that, oh, she's a 44-year-old woman, why does she need uterus? And she's unmarried. So that's where I was trying to bring in the larger misogynistic, or the kind of a gendered hierarchical ways we function in our society, which influence both the doctor, that I don't have to ask, because they thought, that is the doctor, the medical professional standard, I think that's the way the leaning which went, isn't. In India, a medical professional standard is about whatever is a norm which we think is a right, and according to them, it's a doctor knows best. And in this, the judge even also aligned with that the doctor here made a good decision because it was, but then still made an analysis saying that this person, the patient, was not in the life-threatening situation. So then it did not become a criminal negligence, but it became a civil one. So then what's the difference with that is, I still accept, I mean, this is where the whole paragraph in my book, I keep going back and it's still stuck in my head, that how Indian patient, blindly trusted doctors, and doctors have do everything in good interest towards the patient. So that narrative keeps coming and allowed the judge to say that let's give the compensation because the consent form was not done from the patient, so because of the bodily integrity, because still the patient has a right over the body, and they have to consent. So that is the real or valid consent, which is a key aspect. But let's not talk about information disclosure. Let's not talk the patient did not had to be informed about what surgery is best, whether should they have given the options X and Y. That was not seriously taken. I think that's where I was trying to understand, what informed consent ideally is supposed to be doing is, let's sit with the patient, let's understand their perspectives, let's value their beliefs, or even the timing. For example, did this person wanted to even have this at this moment? Even a key conversation would have brought in much more of a. But then why did it happen? This is my analysis, when I was looking at the judgment and larger healthcare professionals' narratives, looking at the ethnographic work, is that these people, very often this language of these people, Indian patients, do not have to have an agency. I think that's a key narrative. Let's not sit and wait and talk to them and figure out when they decide what they decide. I know what's best. I think that's a conversation which kept coming up. And then, I mean, definitely legally, I don't know how much blunder I have done with the legal technicalities, but the key theme which kept coming across as a woman, right, an unmarried woman, going through this. But this happened in the 90s, and then the case judgment came in 2008. But the story is still now, and it's still referred, right? Was there any change? I don't think so, yeah.
Even till date, time.
The same thing, right? Exactly. So then the question for me is, why there is no change, cannot happen within the legal frameworks, is because the Indian citizen or Indian patient is a passive, ignorant, incompetent, which the judge also kind of basically, narrated in the narrative which comes through. And which is not a new thing, having heard from many of the conversations within society of ours, is who, and there is another side to this. I mean, on one hand, health literacy, literacy in general conversation, and also there is other larger middle class value and elite values which comes through in this conversation that an educated patient can make a decision. But actually, very often, educated patient means how could they know better? I mean, that's still there even within the medical, the larger medical professionals. So either way, that's what I started with. Either way, you ask question, you can't ever be active agent in this larger system. But if you don't ask, you are passive and stupid and ignorant. Then where do we go about this? How do we go about this from here? I think that's where the reform is. I think even Sundar mentioned, Amar mentioned, and even all of you are trying to say this. And for me also, right, the reform, the democratic, I think Sundar definitely talks is like democratic self. You mentioned about this. How do we talk about self, democratic self is only when we have self-respect. And people who are marginalized and experiencing again and again this kind of a dehumanizing system and structures and norms which we are in, the only way is we need to come up, hey, let's just push through it. But then not to push through it, the structures needs to have the space. I think that's the space which we need to create. So agency only can be exercised by people when there is a larger society, which is a system which would help. I think that goes back to complaints literature too, with Meena you were saying. When can a complaint be okay? It's okay to question a person. I mean, I think this goes back to family values and the family thing. Like, I need to question my parents and they should be okay with that. And I mean, the same thing goes with the state should be okay, that when the citizens question, the doctors should be okay that patients are asking these questions, and I wouldn't get frustrated, how dare you ask me. I think this is the immediate reaction, whether it's in the family, whether it's in the state, whether it's in the doctor-patient relationship too. So that is like a larger culture of disrespect, I would see it as. I think that's something which I was trying to hope that it keeps coming through. But thank you so much, and I really appreciate your words, and the English, and key point which you mentioned is accessibility. How do we, I mean, this is like, to be honest, I think with Priya, I have lot, as early career scholars who come not from these elite schools and training, which you definitely have corrected me on many of my emails, I know this. I couldn't even have a good conversation without making a mistake. And my professor back in IIT Madras, they never listened to my ideas. They never listened to my arguments. Every time I get into the room, they only corrected my sentences. It's not the. Imagine, I mean, it's like a trauma for me to get into that room without being corrected. Now the question becomes for me is like, as a researcher, now, I mean, after years of whatever unlearning, I think that's what I keep saying, it's unlearning for me is like, what this work is supposed to do is when it is not accessible, right? So you pointed out. And this is my existential crisis right now. So what I do right now within my current work, within migration health for the last 4 years I've been doing in migration health space, or in Switzerland, which I work, it's all the same. The theme is same for me. It's othering, what othering does to a person. When a person experiences discrimination, dehumanization, I also want to acknowledge the agency one person is doing. I mean, exercising. So any kind of resistance or even a silence is an agency. That's how I would see it as. So then asking the larger what this knowledge does, what this writing, what this publish. I mean, now I'm questioning why did I go for Routledge to be honest. Because it's so expensive. That's the reason I made open access with many possibilities, whatever I could. Now, to answer your question, which is really my key issue right now, what am I doing? What this research is for very often, or what am I contributing to this community, right? Is how can I use art-based ways of connecting? So for example, what I do is like in my earlier work, recent work is I talk about othering and ethics of belonging. Yeah, it's like basically a theorization because I enjoy concepts and ideas because it speaks to me in a different way when I connect it to lived experience. That's what I try to do in all my work. Now, what I do this is when I go to meet African mental health professionals in Australia, or I mean, I couldn't have a chance in India to do this because of different opportunities or not having an opportunities. But in Australia, I did have an opportunity where I did this theater of oppress, which many of you are familiar with, I guess. So I used this theorization of othering and ethics of belonging, and I made it as a theater of oppress workshop or a kind of, where mental health professionals, especially African mental health professionals who experience racism, can talk about suffering, which is like how we are othered, embodied othering happens, but at the same time, how do we exercise agency? So something which I'm, working with what this research when I'm not doing. And the other is definitely I'm working on is like, how do I make this work accessible for myself in future? So I'm trying to use very I want to write it in a way, in a plain language. But at the same time, when I'm connecting to different disciplinary crowd, which I was quite multiple disciplinary, which I'm working with, and I don't know whom I'm speaking sometimes. And then I'm like, hey, I want to talk about what I want to say. Let others think, or let others read whatever they want, or whatever they want to take from this. This is how I'm right now is settled in. But definitely it's a learning, and I have to do a lot more unpacking. And it's more of an unlearning and learning journey, I think, definitely.
It's an ongoing.
Definitely, yeah.
And like when it comes to, say, theory, so if you make it too plain, philosophers will feel, oh, it is not theory enough. And so that is something that we keep tussling, with in academic spaces, when anthropologists will tell you, oh, but you went to the field and you could only speak to 25 people. How difficult it was for me to even find those 25 surrogates, but you're not anthropologist enough. Or you're doing conceptual work, but it also has empirical work. You're not philosopher enough. Where are you? So, those kind of questions, and to make it accessible, at the same time, to keep the rigor intact is something that, we keep kind of fighting with. So I can relate to that. And I think you're doing great work with Theatre of Oppressed, because we need to take it to people. And also to not let people gatekeep how you do theory. So, yeah.
Thanks, Priya. And I think quickly to, to think about, like, I think as academics, we have to, now it's my learning, like, we need to give up on this high-end, like, whatever we do, theory, and then just do the engagement. But then I don't know how, sometimes, you don't have competency, you need to learn that too. To connect with larger public, even to write a media article, I realize it's not easy. So I need to learn that too. It's a skill which we need to learn and then be trained in different ways. I think that's there.
Yeah.
In fact, this is what I always think. I know it is not in the control or access of one person to do everything. No. For example, this particular book, I wanted to share with Senior Counsel Dr. Muralidharan. Dr. Muralidharan was former Chief Justice of Odisha High Court, where he was recommended to get elevated to Supreme Court, but for various reasons he was not elevated. And accordingly, recently he applied before Supreme Court, and he has been given senior counsel. According to me, he is one of the rarest of rare Supreme Court or High Court judges, where he can be an ambassador to convey these thoughts. Maybe you just only talk in terms of power and paternalism. I think if it comes from him, I'm sure, honorable judges, etc. I think the various ways, in fact, I wanted you to address, I can facilitate that, in the sense I'll try, Bhopal, National Judicial Academy, when Honorable Supreme Court Judges Training Program, one session by Supriya. Not on this judgment, but how the knowingly or unknowingly the kind of judgments, the archetype, etc. That I'm sure they'll be able to. Because I don't know any reform is possible excluding them. That's not, we need to be inclusive. But having said how, etc., we have to see in what way. With your permission, I'll share this what you call book with Justice Muralidharan. He is one of intellectual judges, and I can tell you, very, very concerned about this kind of writings. Sure.
I think what Sir says is extremely important. Otherwise, what happens is that it is like two groups. See, look, you are bad, we are good. It's not about that. We have to engage with all kinds of people. That's how you, make this idea contagious. It becomes a word of mouth. So creating dialogue spaces is so crucial. At the end of the day, we are talking about governance reforms. I would say governance is all about dialogue. And dialogue influences or shapes the relationship between various actors. So how do we make this dialogue possible with all kinds of stakeholders at the village level, at the policy table, at the higher levels? So that is so crucial. Making these ideas accessible to different population can be done creative ways. Like one is art-based methodologies like Theatre of the Oppressed and all that. But also, as Sir says, identifying possible places, spaces, opportunities to have a conversation in Tamil, in Kannada, in different languages. And you're not alone in this struggle. I know it. So we have to come together, build that solidarity despite all our differences. Only then we can transform something. I wouldn't say transform, it is a big word. Incrementally change things for better.
Thank you. We'll open for Q&A. So questions, yeah. We'll take him.
Thank you, Supriya. When I entered the room, I saw you standing here. I thought as a little college kid, what is she doing here? So you've done wonderful work. And my question, it's not a question, it's a sharing. Both my, as a care, I don't call myself caregiver, as an attender to my father for many years. No, he was been in and out. And also my mom-in-law for a short time. I felt that in my father's case, the whole concept of family physician, you know, if you have a family physician, he helps you around and takes you to a hospital and also says which floor of the hospital you should be admitted. So it happened in my father's case because it was okay, we could afford it, you know. We said, okay, just get into the platinum section of a very posh hospital in Bangalore. Same with my mother-in-law. So somewhere I feel that you spoke about discrimination, right? I wanted you to clarify whether is the discrimination the caregiver and the patient feels in government hospitals or in corporate posh hospitals. Because like I feel like my public relations with the people in the hospital helped a lot, you know, even during the last days. And I could throw my weight around and say, get it done. Because, you know, money was there. So could you talk a little more? Because I feel when I used to be with my father in a posh ward, I would thank God, you know, what are the poor people? Where do they go? You know, despite all the suffering, anxiety I was going through. So like my concern for them, you know, for the poor patients. So since you have gone through it, could you also speak a little more about why exactly you wrote this book? I mean, if you could share a bit of your personal journey, if you don't mind.
I think most of, I think I tend to overshare, some people say that. And even in this book, I have tried to bring in a lot of my personal stories. And to resonate with you, I think the question of discrimination, right? So I think what even Sundar earlier was mentioning, who is a patient, right? A patient is already a person who is suffering. On the other hand, is also vulnerable. It's we go into or we walk into the hospital settings when we are really vulnerable and where we need care. So what I wanted to write in this book is while everyone, when patients who go to government hospital or even the private or corporate hospitals, everyone is vulnerable in different levels and different degrees. Now the question for me became is like when people who are already experiencing social exclusion, everyday indignities, like, you know, you're marginalized. And for example, you go to the bank in India, especially in the rural parts, it's so dehumanizing to just stand in the line. I mean, but this is the story of bank. This is one institution I'm talking about. Public spaces, or when we just even in the any public transport, or the way we get into the restaurants too. Which restaurant, how we walk, what we dress, who do we talk? All this is a different kind of a spaces, public spaces, or the private spaces also has a different dynamics, definitely. So what I was keen on and why this book mattered to me is my own personal experiences. My dad had a heart attack, and even though my parents think that was a very good quality of care, which definitely did when we did not have insurance. I mean, in India, the concept of insurance is a totally different ballgame. And because we had a ESI at that time, but at the same time, one of the hospital here in Bangalore was giving to the poor communities largely. So they were giving the quality. So we got the surgery done. So we got the treatment done. But the way the behavior, right, the way the caretakers are treated or the patients are treated, like you don't even do proper eye contact. Forget about anything else very often. Even in a very good hospital too, this happens. Now the question, as you rightly pointed, is what happens to people who are already marginalized? And very often, and this is a key problem I have every time with government hospital in India is, or the narrative around anything free. So anything free or the patients who go to government hospital, like basically you don't have choice, you're helpless, which is often the case when many patients did say, in which I do mention in my book, is like how that helplessness also sometimes is a survival, sometimes to get things done in this treatment, in the hospital. So then the question is, for me, the discrimination is not about how within government hospitals, so the way you dress makes a big difference between the way they treat a migrant laborer versus a person who comes with a little bit of a decent dhoti who knows around how the system works. As you said, you know how the system works, and also you have a power to demand because you feel entitled to get the care when you have money and when you know your rights certain times or the way the system works. But in the case of government hospital, the most marginalized communities who already experience exclusion and discrimination in everyday experiences, you go and then you again, the hospital which is supposed to care for you and respect you at that critical moment, you are actually dehumanizing again. I think that's where I wanted to emphasize in this book why marginalized communities or marginalized populations needs to be much more of a care we need to acknowledge and why it matters a lot to talk about everyday indignities in these spaces, especially for people who are marginalized. Yeah, I think that's something which I would want to share. And my personal experience has been like in and out in many small experiences. I think this is a key recurring theme. Like when you go, you walk into the clinic, you become automatically passive. Your body just swifts. And this happens even in IIT Madras for me. Like when I speak to a professor or like even anything, my body just clouds. I mean, I don't remember in the beginning I was sitting like this. My body is always like this. So our embodied experience of any care, when we enter any clinic or any hospital, we change. We behave in a certain passive way. But then in order to feel like, okay, we are just, and I think for me, that's where the self-respect matters. At least that's my understanding. So maybe with much more of active understanding of ourselves and the way we have our rights, our entitlement. It's not just free, it's because it's government hospital. It's my right to feel that and to get, to go and access it. I think that makes a huge difference of how we interact with patients and, I mean, the other family members or even with the doctors and healthcare professionals. Are largely system. I think that's something which I would say.
Thank you very much for the sharing. I learned a lot. I'd like to share two personal anecdotes, if I may. One concerns myself, and this is around 30 years ago. I had, for a long time, from childhood onwards, of my early teens, some very strong fears. And after a point, when I was in college up in the north, these fears became very intense. And these were like, childhood fears which I would not address. I couldn't share these fears with anyone. I was too ashamed to share them. I was too frightened. I thought, what do people think, that I'm crazy or whatever. So I kept these fears to myself. But when I reached my 20s, my early 20s, and I was in college up north, it became absolutely impossible for me to, continue that way. And I went to a psychologist. And in those days, I'm talking about 30 years ago, going to a psychologist was like unheard of, right? And I just, sort of shared, what I was going through with the psychologist. And in a very short while, he labeled it as a certain condition. And he says, you have this particular, mental issue. And now these are the tablets that you need to take. And I just passively accepted what he said because, I thought what the doctor says is right. And I can't understand my own self. The doctor knows me better than I know myself. So I took those medicines for more than 10 years. And I didn't care about the side effects. I didn't bother. The passivity, because you assume the doctor knows everything and you know nothing, and what the doctor says is right. And maybe he suggested that you might have to take these medicines lifelong. So I did that. But later, when I grew in years, I realized these fears were unfounded. And these were based on childhood sort of, silly fears that are magnified, unnecessarily. And I began a spiritual practice. I realized I didn't have to continue with those medicines, and I just stopped it. So the point I'm trying to make is the passivity, of course, is perhaps particularly acute among marginalized communities, but it's not exclusive to them. So it was in my case as well. I was passive because I thought the doctor knew everything and I knew nothing, even about my own mind. So that's one. And a second example I'd like to share is of my mother, who passed away around 5 years ago. And she was vomiting. She began vomiting. I think she had some very spicy food or something. And, we're now conditioned to think that for any small thing, you must run to a doctor. Whereas earlier, you would try a home remedy. You would let your body heal itself. But now the first thing that you think of when you have a small ailment is go to the neighboring clinic or to a fancy hospital. So we rushed her to this fancy hospital, And I don't think it was something very acute. She vomited 2 or 3 times, and they rushed her to the ICU, and within 3 days she was dead. I mean, they put all sorts of pipes up her nose, and we were so passive because we thought the doctor knows best. You can't ask, and you're frightened also because if you ask, the doctor might just neglect the patient, or he might be gruff and whatever. So we didn't ask. We presumed that the doctor and the nurses knew better than anyone else, and she was dead. And personally, I mean, I had no say in her going to the ICU. It was my siblings who decided because I'm the youngest. So they decided she must go there. So the understanding is, for any small thing, go to one of these fancy, corporate hospitals. I'm talking about certain classes, of course. And, so she was dead in 3 days. Yeah. So.
Yeah, I'm so sorry. And also thank you for being vulnerable and sharing this. And I think, as you said, I think one of the key conversations which I keep thinking and also thinking out loud here with you all is like how on one hand the structures, right, makes one person. I mean, what I initially said is like how the passive patient is a structural one, the way we are. And the way you're trying to, I mean, at least my understanding of the experiences which you're sharing is about how as a person we buy into this, right? And this is also, I would see it as a larger structural ways how it functions, the power and especially the medical authority, the epistemic authority which the medical fact, the knowledge of our one body, the human body, is aware with only a person who is having expertise in this. That's where we lean on. Mind, yeah, definitely. And then the question is how much, I think this goes back to even how the patients, part of me is also being aware, the health literacy needs to be also a key aspect. And also the way we think about our body and being aware of this is also another larger civic conversation which we need to have. And I think that's important, and also valuing our body and then being aware of how our body and illness matters. I think that's also a key thing, which is also other part of the story when we think of the larger structure, how it plays through. Yeah, thank you for questions and for sharing your space. Yeah, please.
Thank you all so much for an insightful discussion. I really enjoyed it. I just had 2 things to share. One is, of course, I'm so glad that the rights word has been brought up so many times in this discussion today, because for somebody who's been engaged in the right to food and nutrition domain in India, from my experience, there has been a conscious effort to replace the rights-based discourse. It's not human rights anymore, it's human development. And we have been told that we cannot do advocacy, but we have to do systems strengthening or government dialogue, for that matter. So there has been a conscious effort to replace the rights-based narrative. And what is happening is, when we talk about why we haven't been able to transition from passive to active, I think one of the contributing factors is how most of the services are looked at or delivered as an act of benevolence of the government, right? So it's not my right, it is not my entitlement, but it is what I am doing as a favor, as charity, or the free services that we're talking about. So, and there is a huge political agenda that really backs this entire narrative, right? So, dignity, the concept of dignity is largely missing from this entire conversation, because it is deliberately done as an act of benevolence. Whenever we reach out to anybody, when we interact with right holders, again, even legislations that mandate right to food and nutrition as an act refer to them as beneficiaries or consumers, not right holders, something that they're not comfortable even talking about, right? So that is one thing that I wanted to share, how this discourse is largely invisibilized in today's conversations. The second rather concern that I have begun to feel over the last few years is how most of the social welfare legislations in India have emanated from a community-centric movement, right? Whether it's right to information, right to food, the Narega, all of that. But today I see, or rather I'm afraid that there is a reverse transition from the community from the collective to the individualistic. the huge shift is also because the privilege of accessing healthcare or any other service is defined by privileges that certain classes enjoy and certain classes that don't. And so this invisibilization is only is happening with respect to a certain class or with respect to a certain section, and that is completely forgotten. So I'm so glad that we're having the rights-based conversation here. Thank you so much for bringing this up. Thank you.
Thank you so much, Jesani. I mean, I think it's what you mentioned is right. It's like consciously, the conversation has been erased. I think this keeps happening in the health policies or programs and even I think it's a politics, right? The larger politicians, the way they think about health, they don't even, first of all, emphasize any health policies, but when they do, whether it's a food, they want to make their agenda and they call it as a beneficiary, like because it's free, I'm doing this, something, it's a savior complex in many ways to benefit their vote bank. I think that's a key, it's at the heart of the issues. And I think the question then for me is like, the way I would see is like, it's not about passive patient to active patient. To be honest, I don't know whether the active patient, the larger conditions would be in any way soon, which would happen in that. But then, at least the hope in my work, at least I'm trying to understand, is like, as a patient, we need to think from the intersectional, like larger, the marginalized, various intersectional lenses and embodied categories we carry in ourselves needs to be acknowledged. That's where I want to emphasize the recognition. And that means an agency can be exercised only when there is a recognition by the state or the large institutions or in the interpersonal relationships. Now, why I'm trying to hesitate, why I should not switch from passive to active is about, very often active patient is individualistic, and which misses sometimes a larger accountability from the system. How do we hold system, accountability within and hold system accountable? And bring the collective change. I think that's something which we need to, as you said, like it's a larger conversation we need to keep having. And I think we need more spaces to keep bringing these conversations again and again, making it as a center, right? The dignity conversation at the center. Thank you. I know it's late, I'm so sorry, but it's been enjoying this conversation.
I think this book is unfinished. This is only part 1. So part 2 should be like, even if it is hypothetical, let it be. In creative ways, how can we resist at the policy level, at the health facility level, at the judiciary level? Let it be hypothetical, doesn't matter, but let's start somewhere. That is part 2. Part 3, I think...
There's a novel in the making
Part 3,
already,
yeah.
a novel, and then...
Part 3 could be like, it's not that, yes, we are passive, fine, but there is also resistance, and you do acknowledge in certain places. But how creatively people are, that maybe we should unpack a little bit. We need to acknowledge self-respect movements. How do they do it? Strategize. Yeah. So yeah, many parts waiting.
In the end, I would just, firstly I would like to thank all of you who are here. But just, because you mentioned about recognition, and dignity also came from there, and that is a central part of your thing. Just in the end, if you would want to talk about how true dignity for you is the amalgamation of self-respect and social and political recognition, and I think we can end with that.
Thank you. I know it's very late. I'm so sorry to keep you all here. But thanks again for that question. I think, for me, I think I keep emphasizing true dignity rather than just saying dignity. I think that's because of the way we talk, at least in Kannada, the language of ganate. Ganate is very often seen as dignity discourse because of honor or esteem sometimes. But then, ganate is always linked to your social position. And the relation, it's relational. Of course, every concept is relational, but it's very much attached to your identity and your social positioning in the larger, so the status and the ganate you get from where you position, so which I do not want to do it. So that's the reason I emphasize, at least I try to do is self-respect, acknowledging oneself and respecting oneself with the larger humanity. Is like, that's what I call it, self-respect plus humanity is what true dignity can be, or it could be possible in the larger, system. Comes in. And recognition is a key part because it's an intersubjective aspect, right? Only when I recognize you as a person, you would have, or you as a person would feel acknowledged, and then you will have a self-respect. Because in a oppressive conditions, very often, dehumanization or humiliation keeps targeting your oneself, the self-respect and the dignity, that is humanity, I would call it. And that's, recognition is a key part, and it's very often comes at state, institutional, interpersonal level. And if a person is experiencing everyday dehumanization, then once self is completely, then you need to really do a lot more work to come up with and retain your self-esteem and sometimes even a love. Self-love is, that's a whole conversation on altogether. No spirituality yet, but self-love. I think love is another whole way how we can talk about respect is important. But again, I have not done much of work on that. I know, because I'm a fan of bell hooks, so that's there.